You want this, who else to come in? Anthony Batunga. Fair. Go ahead.
Thank you, Speaker. I wish to give the background of the statement of the country. The Honorable Member noted that the citizenry have some recent raised complaints over the operations and service delivery of the Makueni County Referral Hospital, with the complaints including laxity and negligence of work, harassment of patients by the medics, lack of medical drugs at the facility, and inability to use the Makueni County Universal Health Care, that is with T card, and the National Hospital Insurance Fund, that is the NHF funds. The Honorable Member informed the House that it was alleged that the turnaround time at the casualty has gone outside the time provided for the service. Secondly, it was reported that an accident victim stayed over 3 hours at the casualty without being attended to. Thirdly, physically assaulting the patients. Further, the Honorable Member reported that the UHC and NHF cards were no longer usable at the hospital, and the patients were not being given any reasons for that. For the same, the hospital insists on cash payments, a situation which has put huge medical financial burdens on the facility, and once medication has been prescribed, the patients are sent to certain chemists and pharmacies to buy such prescribed drugs, a practice which has raised eyebrows. And the various questions which were raised, I wish to read. First one, whether the department is aware of the monitoring of operations and services of the county referral hospital, especially the county referral hospital. Two, if yes, what actions has the department taken to remedy the situation, provide a remedy for each reported vice, including laxity and negligence, harassment, among others. Three, provide the organizational structure and the staff establishment of the facility in the Makueni County Referral. Four, a satisfactory reason as to why the hospital no longer accepts the HC and NHF medical insurance cards. Five, why the hospital lacks the medical drug despite the county assembly having appropriated 288 million to the financial year 2020. And the actions the department has taken to ensure of drugs at the hospital is restored. Six, provide the names of the specific chemists or pharmacies where patients have been referred to purchase the prescribed drugs and where those specific chemists pharmacies were chosen. Seven, whether the hospital has public complaint box and a portal, and if yes, provide a list of complaints that have been raised by members of public, patients, and staff, and indicate actions taken to address the complaints. 8. Whether the service or services outlined in the service charter have been operational in the last 6 months, and if not, why. 9. We have Makueni is a referral hospital, yet patients are referred to other facilities, including private hospitals, to get services. Yet its status is a referral hospital. Substantiate that. Whether the hospital has been referring patients to private institutions, hospitals, laboratories, for imaging services, and if yes, which are these services that the referral cannot offer? Why are the universal healthcare card, Makueni, not accepted in the facility? And we have why the patients being referred to specifically Kaichi Pharmacy, chemistry, and Makueni medical services for purchase of drugs. Then, which health facilities have been contracted for referrals, for specialized rheumatology, and biochemistry tests? Lastly, whether the said one customer care line is sufficient and effective to serve many clients. If not enough, what plans does the department have to ensure that there are enough customer care lines, and how the department does sensitize people on the use of the same line? Thank you.
Honourable members, I wish to inform you that when that statement was raised on the 8th of September, year 2023, the executive commitment about the clerk of the county assembly responding to the said questions that have been read out. I presume that every member has a copy of that response. Is that the case? Honourable Fiametta, do you have a copy? Honourable Zai? Leader of minority? Okay, fine. Advise members those who do not have a way to get to that. Was it? What is your take on the questions as raised because I found not to be satisfactory when they were presented by the chairperson before this house?
Thank you. I don't know whether at this point to actually begin by making some general, statement, which before we go to the specific, and just to remind you that it's exactly 365 days since I sat upstairs on 26th of October 2022 for the vetting. And we have now an opportunity, myself as and also the department, to actually sort of like give a scorecard of what has happened in that 1 year. When I came in, there are some aspects of the department which I realized need to be, looked at, and we also went to the leadership in the department. So I've been the ECM. I have to advise the governor, and I have since done the advice that one, for us to increase on efficiency in the department, there are three changes, fundamental changes I would really suggest that we make. One of them is that the chief officer position is overwhelmed. Half of the employees that you have in the whole 240 medical health facilities, there is an opening of another and Kyoto. We get us to advert go out to Makueni County and Referral Hospital is big. We have a capacity of 420 in the medical hospital today, and we have 800 clients. So we are actually not being fair to ourselves and to our officers and to our clients if we continue to have a medical superintendent who is also acting as a substantive CEO for the facility to basically run the facility. The next thing that we have done is automation, and that's to actually see what is happening, not just in MCRH, but also in facilities in IT. And this will go a long way, and it has already done actually, gone a long way in enhancing the efficiency that we have in the department. Some of the successes that we have with that is that she will tell you that I want to bring out the issue that we have had serious discussions with the board, the County Public Service Board, and we have seen some. Do you want me to go through the answers, or do you want me to answer? Just
You have to go to the answer. In a very short way.
yes.
Because you realize that the answer to question 1 or question 2.
Number 5 is
Then the contacts that have been provided.
Want to approach you for the stages that you meant after this statement. That means that you are concerned that there is something which is not happening, and you have tried to rectify it. Thank you for that. what I wanted to know is how have you structured this customer care? How is it structured? Because I think the line that you just given is just one line. And when we requested to know if it is able to serve the whole of this county, because this is a referral hospital, we were given other alternative lines which will come here, like ICU line, it's a customer care line. I don't think it will need more of these lines, leave alone lines from other departments. We need, because like if like 10 patients are calling this line and it's only one line, it will not serve them well. So we were thinking that you have gone an extra mile and maybe have more of these lines, maybe like 5 lines that can serve our people if we are serious about this. The other thing is, I happened to visit the customer care desk in the hospital, and I realized that it only once within the day. I was there some minutes, actually after 5, and I found those actually who normally attend to that customer care were actually parking and leaving at that time. And I made question, you only work during the day. So it's important to know this customer care desk, if it works 24 hours or how is it? Again, when you pitch attend there at the cage and call it customer care, we will know that if a patient comes and probably want to go to casualty, it's new in the hospital, how will they direct them? Because it is actually a site, just a site, no one will know it's customer care, because I believe that customer care should start from the desk, where at the gate, if you are just coming in, you need to, if someone talks to you, what is your problem, where do you want to go? That is what I believe about customer care. So it's not just a term, it's a site, and people are just seated there. They do not understand when customers ask us where they are going, what is their problem, because for the last 1 week, I normally move around that hospital, and I realized that people we need to help our people understand where they are going, because the hospital is big. If you are referred, like I wanted to see one of the patients, and I was told it was a baby who was sick, and I was told the place where we used to have COVID is our new ward for babies. Something I did not know. How do you expect if I do not know and I'm from around and I'm the MCA for whatever the hospital is? How do you expect someone from Kikumbulu to know where the new ward is? We need to get explanation. We need to understand whether there you will be your problem will be. And if we are serious with our oversight, yes.
That
Mr. Speaker, this is a very serious oversight. And Mr. Speaker, the issue of praise and worship, we will win. So let us get it right and not waste time in all these. I mean, show.
We are here on question answer time. We invited the executive committee members for questions and answers. Address yourself. The questions as they are and answers so that the questions are satisfied. And if there is something that you can take up out of the question, then before we go to the next question, if we could,
Mr. Speaker, the issues and comments are crucial, and I'm glad that it's raised in the right place because you have the CCA. That passes budget, so that you don't come out here and you go, if there is any financial implications of tax you may need, it is very important.
Who are actually not mainstream employees of the County Public Service Board. These are one part of Yes, thank you. These are partner supported, and then we have the hospital contracted staff. The hospital contracted staff are paid by the hospitals using the monies that we collect from the hospitals, the FIF, kitty. We basically spend about close to 200 million shillings per year on hospital contracted staff. What this means is that we have a shortage of staff, because all these ideas should actually be absorbed by the County Public Service Board. So we will see if the budget allows, or if we can actually discuss at the supplementary, because we have made a proposal for enhancement of our recurrent, budget, which we have forwarded to Waziri Finance. If considered, then we'll look at the possibility of having this desk run 24/7. The lines, I agree, one line is not enough. We have actually other lines which are available, like the toll-free line, 0800 721 782, and then the emergency operations center line for the ambulances. What we have realized is that these numbers are not as publicized as they should be. So one of the immediate things we are going to do is make sure that all the meter towns have these numbers, and then quickly to that we can add another line, and I think the medical superintendent is here. We will add one more line to be at the customer care desk. The other lines, as they appear, remember that this is a county referral hospital, so our clients are not the citizens only. The other facilities, both public and private, are also clients of the Makueni County Referral Hospital, and they make a decision on where exactly they want to call. If the patient is in Makueni and requires ICU, then they will call the ICU straight or the newborn unit. So the numbers provided will be utilized by the other clients.
And therefore, you agree that that is an area of deficiency that you deal with.
This we will deal with. Some budgetary constraints, we will see how to, work around that. If possible, we will be allocating some more money to the supplementary. We will actually actualize it immediately.
I think the point of concern is management and the flow of patients and who are customers in the hospital. And how that smooth running is organized is what Honorable Mateso is speaking to. They require financial human resources, but again, without it, then it's going to be confusion. And it's a big issue. And this being at far, I think that is important.
Thank you, Mr. Speaker. We are actually working on the signage, the medical superintendent, the improvement of the signage within the hospital, so that once you get into the corridor, you can actually move. You don't need, because initially that's why there are two people in the desk. One will escort you to the casualty, the other one is left man in the facility. But once you get in the signage, we will work on that.
On the side, there was an issue on management of the casualty, lack of a doctor at the casualty. Is that a question number one?
We now have two in the casualty.
We now have
two medical officers.
meaning they were not there, but now we have two.
We have had to engage actually using the same system that I mentioned. We have two medical officers.
Any question on that? Is member from this one? You address that issue?
Yes. Thank you, Mr. Speaker. Mr. Speaker, I want to disagree with that response. Mr. Speaker, last week on Saturday, I visited the facility at around 5 p.m. We had a patient there, and up to 10, he was not attended. Reason being that they are waiting for a doctor to attend. So I don't agree with that response.
So when did the doctor show up?
I had to call the CEO, and after 5 minutes, the patient was attended.
Was it?
Mr. Speaker, can I request my chief officer to respond to that specific?
You called me chief officer.
Because
The chief officer for health. The chief officer for health or another chief officer?
Chief officer for health.
Dr. Lord is quiet. So Before then,
Mr. Speaker, just information to Waziri and the team that immediately you enter into that house, you are under oath. So whatever you are speaking is assumed that it is nothing but the truth. Just to inform.
and I think the leader of the region is very protective. But that is the leader of the government business. Therefore, it should mean that any information that is given and this committee, either in writing or on record, there is nothing but the truth. Misleading information has serious consequences. You'd rather give information as it is, whether it's pleasing or stinking. That doesn't matter, it's not a problem. The problem is to give misleading. Thank you, Leader of the Majority. The Chief of Staff.
Thank you, Mr. Speaker. My name is Dr. Stephen Dolo, Chief of Science Services. And as I respond, I want to make an observation in the Constitution, Section 43(1)A, where it says, under economic and social rights, every person has the right to, and the Section A says, to the highest attainable standard of health, and it continues. Mr. Speaker, the two medical officers that have been highlighted to be in the casualty department, we can only sustain it through budget during weekdays when the numbers are high, and it's weekdays during the day. The budgets cannot allow us to have this medical officer cover nights and weekends.
Allow me to interrupt you. You have gone the way forward.
I'm answering.
So it is proper, if you solve member from this issue, and then you make a recommendation to explain, because the process of answering the allegations or statement that is made, then after that you explain the cause as to why that will happen. It will resolve the question faster and go to another one.
So, Mr. Speaker, during the nights and weekends, like he highlighted, there is only one medical officer on call covering the whole hospital. So for the time that the patient had been waiting, is because the same medical officer was covering emergencies in the other departments. And when he called, he actually called me, it was around 10 p.m. I reached out to the hospital, and the medical officer was just winding up the emergency, and that's why he was able to attend within a short time. So as the Waziri has highlighted, there is limitation of budget, and currently our staffing levels, we are supposed to be at 45 per 10,000 population of healthcare workers. We are operating at 7 per 10,000 population of population. The nation is at 13. So our staffing level is below the average for the nation in terms of the staff per population. So we are trying to provide, but the highest attainable is constrained by the budgets.
Okay. I think member 14 is related to the question as answered. And the answer is from the department, a letter signed by the medical officer have been deployed the casualty for specialized consultations and timely decision making. Now, is refuting that fact arising from an answer originating from the office of executive management? That was the basis. But you see that explanation has not been given, depending on what was it on night or was it on the weekend?
It was at night, Mr. Speaker, and Mr. Speaker, as we speak, there is flow of information. I had to consult with the nurse at the customer's care desk, and he informed me that a doctor is coming, but he can't tell what time, and he's not aware who is the doctor who will attend the patient. So there was no information.
So was it, if that was to be a case study without simply down on that specific matter, because you are not conducting an inquiry on a misconduct, you're picking it as an issue against an answer that a doctor is in place, then is it resolving the problem? Because what you've been given at CEO is very clear, that at night there's a doctor on call who may not be available immediately. Over the weekend, Saturday and Sunday, one doctor is on call. Then how would we help our people not to be sick as much at night and over the weekend? Because you cannot control that parameter of visitation to the hospital at night and over the weekend. And then is it a cardinal rule that you do not have doctors as many over the weekend and so many during the day and the weekday, such that then why is it their practice to rationalize? Just like a private hospital, you will not know whether it's on a Saturday or on a Sunday or on a Wednesday. You have explained why there is a gap, but that gap will continue to contradict the answer. And the problem around the casualty and the question by Nadeso on e-caps at the casualty. That is what we are addressing. Chair, I give the opportunity. I would present to please just one more member, just a minute. What do you want to respond? You want to pick on the same, not a different.
No, I want just to pick on the same.
Okay, briefly, precise to the point.
This is my concern, because the ECM has just responded that the department has now 2 doctors, but in contrast to the team when they are at 10 and calls a CEO. Now my question is, Honorable Bitini was lucky because he had the contact with the CEO. What happened to those people from villages who lacked that contact? What estimate period would that person have taken to get the treatment? Because it was only because that the advantage of Bitini having the number of the CEO that got the assistant. Thank you, Honorable Speaker.
What was it? I think the question is better clarified.
Yes.
By member from Maryland.
Could I clarify something,
Yes,
Mr. Speaker? When we are talking about a doctor here, we are talking about a medical doctor, medical officer. The clinical officers, the nurses, are in station throughout. So this client has already been seen by the clinical officer. The treatment has started, the stabilization, or they have been recommended for a second review by the medical officer. This is it's not that there's no one to attend the client. We have clinicians available 24/7.
But was it if you listen to MCA from BT?
After the clinical officers have done what they are supposed to do, there is need for intervention by MO, a doctor, that it is on a Saturday or past 6. That he was lucky that he got an intervention after waiting for so long through the chief officer for a doctor to be availed to do that which a clinical officer could not do. That is the argument. Now, Emali is asking, Bitini is so lucky that he has a contact for the chief officer. What happens to another person who may not have a contact for another else person to help to reach the doctor? Because presumably, when the case was reported and there was need, then systems would have flagged the doctor and the doctor would have been there in a particular time that the officer handling the patient would have promised. For example, if the nurse or clinical officer indicated, we are able to manage, but within 30 members of 1, 2, 3, 4. Of Kimongo, of Nambuki, of Ukia, of Mutie, Tange, Mwema, and Joseph Bidio. I'll give each, just take a pen so that you are not interrupted. Get a pen and pick the statement as they will be put cross. I will start with the Honorable Bidio. Honorable members, if you are not interested in speaking, please drop the request.
Yeah, thank you, Mr. Speaker.
Precise to the point.
Yeah, I can, Mr. Speaker, a patient was brought from Longo last night, and I'm now receiving a message here. Up to now, he has not been attended to. So when we say that there is a problem, it is true that there is a problem. There was another time when a person passed on, and then he had to be transferred to Kelongo mortuary. Then the officer on duty refused to release the body until I also called the CEO It was after his involvement that the officer allowed the body to be moved to Gelongo. So let us accept that there is a problem and then look for a solution. Thank you, Mr. Speaker, sir.
Member from Tiswande. Thank you, Speaker. I'm worried because the way they are saying, like you have been referred from Makindu to Wote. I thought the moment you arrive in Wote, you have a file from the doctor who has referred you to the Makueni Referral Hospital. Would you again start the similar tests? That is the problem, because you start again, and that is a cost implication to our people. So we need to be very clear. Because last week, the woman who was trampled by elephants, before she left Makindu to Kenyatta Hospital, I was there with Dr. Mutinda. A file and a scan had to be done, and a file provided for the lady to Kenyatta Hospital. So why does it happen? You are referred from Makindu, you come here, you start again the process. That's where now people are complaining. You need to come, go straight to where you have been referred and get the attention you need. Thank you.
The issue is on duplication referral.
Yes, and it's a cost. It has a cost implication. That's why people are saying you are referred to an external facility, a lab, to get another scan. When you had another scan where you are coming from, like Makindu, why should you start it again? We need to be very clear once you are, and I think I'm not a doctor, but you have to have your file with the reference, the way they do it. A file complete, which will take into the specialist at Water, and we start without now starting again, going out for a test, for a lab test, for a scan, MRI, for that file to be.
Your point is meant. Honorable Mbalu.
Thank you, Mr. Speaker. Mr. Speaker, Waziri, and I really wish that you be truthful on this and give the picture, because I know what is happening is you get one covering medical officer at night, and he's the one who is reviewing patients in each ward. They are being called from one corner of the ward to another. And yet, there is a clinical officer at the outpatient seeing patients. So, those who are referred to that doctor, they still wait for the same doctor to go around, and those who are being referred from the other hospital, they must come through. So I want you to be open and tell us implication we need how many doctors to cover that, because there is a gap. Because if we don't tell it here, it is, we'll come out and you'll be skinned still. So come up, how many doctors we need in Water to be able to cover such, because the practice, what I've said is what happened. And it is very difficult to have one doctor looking from ward, if is a patient for whatever. How many doctors? What is the implication? The staff number, the number of doctors. It is important that to put it here so that we may know where we are. Thank you.
Okay. Honorable Mbalu, you are taking more of a chair. So allow your colleagues first, then you come last. You are winding up. Brian Zoga.
Nashukuru sana Mheshimiwa Spika. Nataka niguzie kuhusiana na kuzembea kwa wafanyakazi katika hospitali zetu, na nitaongea kuhusu jambo ambalo lilitokea katika wodi yangu ya Masongaleni, hospitali ambayo inaitwa Masimbani, tarehe 15 mwezi wa 8 mwaka huu. Na ni kesi ambayo ilikuwa ni ya mama ambaye alikuwa amebahatika kupata mimba, na alikuwa ameenda kupata
Mheshimiwa Masongaleni.
Yes.
Nakuradhi ukubali, iwapo una swali usichukue muda mwingi.
Basi.
Kama una mfano unaopatiana basi uwe kwa kifupi sana.
Nashukuru Mheshimiwa Spika.
Sije basi
tukachukua muda mwingi
kwa dodoo lililo hapa. Na muktadha.
Endelea.
Nakushukuru Mheshimiwa Spika. Kesi yangu inahusiana na uzembevu ambao unatokea kwenye hospitali zetu, na kesi inahusiana na huyo mama ambaye alipata kupoteza mtoto kwa njia ya kujifungua, na hii ilitokea kwa sababu alienda hospitali, akafika akampata daktari, lakini kwa bahati mbaya daktari akakosa kumhudumia. Akamwambia yeye hayuko tayari kumhudumia kwa sababu ana zile gloves za kutumia ndio aweze kumzalisha. Mama akarudi nyumbani mpaka akaenda hospitali Kibwezi kesho yake, lakini kwa bahati mbaya mtoto hakubahatika kuzaliwa akiwa hai. Hiyo ni kesi ambayo huyo mtoto angezaliwa akiwa hai, lakini madaktari wetu wakalegea kidogo na tukampoteza huyo mtoto.
The context of this is customer care and a turnaround period within which a patient is attended to from customer care and the casualty, and that is where we are in question number 1. Now, Honorable Member for Masongaleni, you have given an example in your ward.
Yes.
Member for Kilungu, you have given the same. So we have taken enough samples that we have, and because they have been pointed out, then it follows without saying that every member was to speak and citizen will raise an issue, so that we don't over-repeat the same examples, because repeating in your ward will not resolve the problem. Picking the issue and giving a cross-cutting solution to all other hospitals. So if you're requesting to speak on that, but may you please drop. We have 5, 6, 7 sub-questions to go. Yeah, I will give you, but I want to say how many will drop, so that if you give an opportunity and you repeat examples again, then you'll be out of order. Member for Tangawat.
Thank you, Honorable Speaker, for this opportunity. Honorable Speaker, I want to advise the Waziri.
Member for Tange, we are not in advice time.
Thank you. Okay.
It will come later.
Let me put
what is your question?
Okay, let me go straight to my point.
On the subject part.
Yes. Honorable Speaker, we have a problem with the department, and it is good for Waziri and the team to accept. And then we can also plan for, as we go for the supplementary budget, we can plan for what they need so that we can better our hospital. Honorable Speaker. Otherwise, they will keep on defending themselves and will keep having statements after statements after this meeting, Honorable Speaker. It's good. We accept. We have a problem. We are serving the same people of Makueni and outside. If we accept and stop defending or sugarcoating our issues, then we will keep on going on circles. So it's in order for the Waziri and his team to accept we have issues, and then we solve the issues. Thank you.
The Waziri Javota.
Thank you, Mr. Speaker. Mr. Speaker, I am sure once we come out because of interest of time. And Mr. Speaker, I wanted maybe to highlight to our minister and his team. I don't think there is a problem, Mr. Speaker, if we were to borrow what the private hospitals are doing, and especially on customer service. Mr. Speaker, I would wish to ask the team, is it so hard? Why don't we think, for example, creating a customer care, is it a call center, so that all the calls, the emergency calls and the rest can be managed by a team dedicated, trained to do that, so that no one will call, whether daytime or night, his call or a call will miss out to get a response. Number two, Mr. Speaker, we are referring to Makueni Referral Hospital. And once it is called a referral hospital, it means then a patient arriving to that referral hospital has gone through other hospitals, and that patient is critical in nature as far as that illness is concerned. And therefore, Mr. Speaker, when we say, and I had the Chief of Staff say that we have a medical officer who is on call. So that person is called when we have a patient. And remember, this patient has been referred from another hospital in critical situation. Mr. Speaker, I would wish that the department looks at it in a way that we have standing medical officers, doctors, because once someone is critical, that person does not need to be managed by nurses and the rest. And
fair enough.
around 4 or 5, Mr. Speaker, medical doctors should be placed in the referral hospital to handle. And Mr. Speaker, lastly, it is on the numbers he highlighted. I'm sorry to put it that way, and I agree with the ECM when he said, even comparing Makueni Referral Hospital with Kenyatta National Hospital, that we are receiving more patients than Kenyatta National Hospital. That means even the patients arriving at casualty, Mr. Speaker, at critical stages are more, and therefore it qualifies for them to request for about even 10 officers, both night and day. Thank you.
Member for Ukia Ward, Honorable.
Thank you, Mr. Speaker. This area of casualty handling in our Makueni Referral Hospital is one of the area which is raising serious concern in our county. And Waziri, I would like, if you have said there are doctors who are standby, but my concern is the way a victim or a patient is handled once he gets to the hospital, like for example, accident victims. You realize that victim once is received, some of them are supposed to go to x-rays. You realize our x-rays are not working. You are referred to do an x-rays outside at the doctor's plaza. You come back, you find that nobody to interpret the x-rays. You wait and doctor is looked for. Once the doctor comes, you are referred to maybe to Kenyatta National Hospitals. That period of handling casualties in our hospitals is what we are raising concern with. And it is an area which actually needs a serious intervention. Waziri, Speaker, you have said it's not good to give a case study, but allow me to highlight a case in Ukia. We had a victim, an accident victim. Yes, an accident victim who was brought to Makueni Referral Hospital at 6 in the evening. That victim was referred to do an X-ray outside at the doctor's plaza. It took time. They did the X-ray. He came back. Once he came back, there was nobody to interpret that X-ray. And doctor came at around 1 to interpret that X-ray. Once he came, he was supposed to be referred to Kenyatta National Hospital. There was no ambulance. They had to look for an ambulance. They were told to pay. They paid, yes, but he was supposed to be taken to that referred hospital, that is Kenyatta National Hospital, the following day at 7, Mr. Speaker. That took for more than 12 hours. That is what I want to ask our ECM. Will you justify such a time period to handle an accident victim?
Your point is made.
Thank you.
Honorable Elizabeth.
Thank you, Mr. Speaker.
If you pause, you can skip.
Not really. I wanted to add on that. I understand maybe we don't have people to do, but they are the government has contracted specific institutions to read for us these images at a cost, Mr. Speaker. So I don't understand why we have to wait for so many hours for that interpretation to be made. Then it means that we have contracted very slow people who are not helping our people. Because if it's a case of emergency, how can it take 3 hours for the image to be read so that a referral is done? Mr. Speaker, I'm aware of that case, and the patient had died while being before the ambulance left the compound, Honorable Speaker. So now you have to now start tracking for your money to be repaid because the ambulance has not been used. Mr. Speaker, we want to have our own, because we have our own scanners. Why can't we just have our own people who can read the images? What is so expensive about that? Thank you, Mr. Speaker.
Honorable Mutindi, there's a question number 7 on laboratories, images, pharmacies, and all those services. So you will skip it, and it will be sorted at that time, so that don't mix up. Honorable Kimongo, I think that is the last one.
Yeah, thank you, Honorable Speaker. Honorable Speaker, I want to state that we have some of the best medical practitioners in our MCRH. Very good doctors, very good nurses, and so forth. But the issue is what Honorable Matelso nailed from the beginning. The issue of customer care. And I want to say, customer care is not a noun. It is a verb. A verb is used to illustrate actions. A noun is used to illustrate things. What we need is not a customer care desk. What we need are not lines. What we need is not a staff. We need people who are ready to give service. In fact, if I can define customer care from the dictionary, it says it is the act of helping customers in discovery, use, and troubleshooting. We only need someone to show a patient, someone who has arrived with a patient who has broken a leg and has arrived and wants a stretcher to wheel that person to the casualty. We only need someone to reply a question like, where is a stretcher? A sweeper who is cleaning the compound can do customer care. They can tell you the stretcher is there. We need someone who is writing the receipt pale kwa kuandikisha ile receipt pale kwa nini. Umuulize, and when can I see the doctor? To tell you, today is a weekend, you may take relatively longer, but please be patient. That is customer care. We don't need lines. We don't need people. We need people with a human face in the compound of the hospital. Right from the man at the gate, to the person sweeping, to the person doing anything, the watchman there. We need someone, everybody there must be able to do customer care. And that is what we are lacking in our hospital. You meet a watchman, unamuliza, where is the casualty? He tells you, that's not my work. You meet someone sweeping, collecting rubbish, you ask them, where is number 5? I've been told to go to number 15 to pick a receipt. They tell you, angalia pande hiyo. That is what we are lacking, and that's what we need. Thank you.
Honorable members, I want to plead that we end at that so that we get responses, save for Minority Whip. You are on the queue. Honorable Redis Musyoka, you've come in too late. On your request, I will allow you to speak first on the second question. Honorable Kali, very briefly.
Thank you, Mr. Speaker. Mr. Speaker, we have come here today to talk the truth because the reputation of our hospital is also going down, Mr. Speaker. And if, Mr. Speaker, I recall what member for Bettina said, that if they went to the hospital and the patient waited for more than 5 hours, that's a big concern. And then member for Kulunga said that a patient went there last night, and at this time, the patient has not been attended. And that tells us that is more than 12 hours. Therefore, Mr. Speaker, that is just very worrying. We may understand as members of this House, but the community, the public at large, may not understand. Those are not the patients who are going to the hospital, Mr. Speaker. And if I recall, if I remember, according to what Wazira said, if we have 2 doctors, Mr. Speaker, and the day before we had 1 doctor, supposing now that doctor, the phone now goes off, and we have a patient who needs to be attended, or else we have 2 doctors in place, but 1 doctor may go off, and then the other one may get sick. Then it means we have a challenge there, Mr. Speaker. So when the budget is also being talked and not talked, then we need to get somebody to address that, Mr. Speaker. Number 2, when you're talking about the customer care desk, the face of the hospital depends on whom you have met at the gate at the first entrance. So if the reception at that particular point is not welcoming, then the patient may go saying that the work of the doctors and also those who are attending us, it is not up to the date. And then that reputation may get into the community, then we are missing the point. So therefore, Mr. Speaker, it's very important. As we talk about the budget, we talk about the doctors who are there, then this need to be arrested as quickly as possible. So thank you, Mr. Speaker.
Executive Committee member.
Thank you, Mr. Speaker. We have, as I mentioned earlier, engaged one of our partners, Thinkwell, to assist us in the training of our customer care officers, and this will happen within the next 2 weeks. We have an advert that is out, and within that advert for employment, we have the position of a radiologist captured as one of the officers that we will be seeking to recruit. That one is out already and being processed. We have an ideal staffing ratio and numbers of medical officers in Makueni County Referral Hospital of 20. We currently have 8. We have a deficit of 12. For us to cover the hospital effectively, the medsup tells me that he requires an extra 12 medical officers. The chief officer is scratching his head, but we will be putting forward a request for an extra 12 medical officers that will enable us sufficiently cover the facility. What we have, the medical officer who is covering, who's on call, is actually not being called from home. He's actually in the hospital covering various departments, but getting called back to casualty at night and over the weekends. So if we could get an extra 12, then this coverage will actually be optimal. The referral system that was brought out by Deputy Speaker is something we are actually in the process of curing with the automation process that we are embarking on. Because as I mentioned earlier, when you are seated, especially seated in Makueni County Referral Hospital, they have no way of knowing, unless maybe a phone call, they have no way of knowing that a referral is being initiated in Kibwezi, for example. But once we automate and the system is integrated, then this will actually be captured. As soon as the referral is initiated, then it will be captured in the specific clinic that this client is being sent to. The automation is work in progress. We have officers currently in our county from the ICT Authority of Kenya who are mapping out the requirements for this automation. Once they give us a report, then we will be tabling it in cabinet, and then we see how to go about it. Thank you.
First of the statement, Robo Mateso.
Sorry, Mr. Speaker, if I may, I've forgotten to mention the ambulances.
Allow him to speak so that he may raise an issue that you know to speak. Go ahead.
Thank you, Chair. I think we've had the plans that the department have on customer care, and the words by Honorable Kimongo are very weighty on this issue. I want to give a scenario that happened. That time you are not there. It was the other regime.
somebody brought a patient who was very sick, and the security team denied that customer who brought the patient from a parking that was meant for the hospital superintendent. And there was a lot of fights. A patient very sick, was empty, and the security team are fighting that particular person who brought the patient. That tells you that if you plan to train even the security team, because that is where the image at the gate will depend on who you are found there. So that is something we want to add on what you will be training if you are to do any training. Again, I think it's important once we speak, or the plans that you have should actually be implemented. We don't just speak and that's the end of everything. I think you should implement, and I personally, I will just follow up. I will always follow up on whatever is being done. I'm a frequent visitor to the hospital and just go without notice, and there's a lot I have for that hospital. So thank you so much.
Concluded Max on that question. Question was it? And whatever else you wanted to say as we go to the next question.
Thank you, Mr. Speaker. I want to assure Honorable Mateso that the promises that we are making, that will be done. The others that will be requesting for your assistance to avail budgetary support to engage the extra 12 medical officers, the way you actually supported us. Now we are buying 2 extra ambulances. We have 8, and we are buying 2 extra ambulances this financial year. This should be available in the month of January. We will be left with a gap of 5 as mapped out in the county, but with it will actually improve on the referral system. Thank you, Mr. Speaker.
Honorable, we hear what you've said. I think the secretary is taking the notes. The second question, or the third question, was to provide the organizational structure. I think it has been provided. The committee will be able to scrutinize. And then other than providing it, the organizational structure, it looks so good. It's important for you to make some comments on how it can be improved, budgetary allocations, and I think that's a little bit technical. Then we'll go to the fourth question. And the fourth question is on provide satisfactory reasons why the hospital no longer accepts the Makueni Universal Healthcare and the NHM medical insurance. You have the answer with you. And then after that, I can take a maximum of 4 comments or supplementary questions of the same. What's your answer?
The hospital accepts both the UHC and the NHIF cards. The hospital has dedicated offices staffed to provide UHC and NHIF services. The challenge we encounter occasionally is on system downtowns, since both systems are run on online platforms. The server for the UHC is based at the Deputy Commissioner's office. When it has challenges, this affects service provision in the facility. The NHM website sometimes actually on its own, now independent from our own domestic challenges, gets slow and unresponsive, and we have to wait for it now to be reactivated from their side. However, we are able to relay timely communication to Makueni branch, and there is no occasion we have not denied anybody service. The hospital has 3 streams of revenue, that's cash, UHC, NHIF, and only basically persons who do not have UHC or NHIF pay in cash, or where services are not covered under the schemes. I think we need to add the other insurance schemes like what we have as members of staff are also accepted in the hospital. The hospital has a medical social worker who determines needed cases for waivers or exemptions. In the 8 months ending August 2023, the hospital has waived bills amounting to 5.2 million. No patient has been denied services because of lack of money. Since I produced this answer, I have been having, Mr. Speaker, a discussion with my colleague, ICT, on how we can enhance.
When that answer was given, as you provided, it brought supplementary questions on as to what was the meaning of UHC. What was it, Honorable Matezo? Because if you get there's NHIF, there is UHC on website platform. According to the request of the statement, is that the UHC is referring to is not on website and is not hosted at the county commissioner's websites. It is hosted by the county. Honorable Matezo.
Yeah, thank you, Chair. It's good to make clarification on the UHC I meant. And the UHC I meant is the Makueni Universal Healthcare. That is what I meant. It's good to get those clarifications. Thank you.
Honorable, who's that? Go ahead, Waziri. That's a clarification that was sought.
The Makueni Care Card is accepted in Makueni County Referral Hospital. The Makueni Care Card has a waiting period of 2 weeks. So not as it was, as I was told before we came in, initially it would have been instant previously, but the amendments that were made even before last year, it now has a waiting period of 2 weeks. So a client walking in cannot, if they don't have a card, they can't use the card immediately. If they enroll into the Makueni Care, right, they have to wait for 2 weeks for it to mature. And then it also has limitations on some of the services that it can be accessed using the card, and it's clear to the Mwananchi on the same.
So, Honorable Fiametta.
Thank you, Honorable Speaker. My concern is Waziri used instant. Patients could use it after registration, now which takes 2 weeks. So what happens to that citizen who cannot afford, maybe to go to private hospital and get sick within those 2 weeks? Why is it not, immediately as it were previously? Why should a resident of Makueni wait for 2 weeks, yet we don't know when sickness will come or a member of a family gets sick and they have to wait for 2 weeks, and maybe they just paid for the universal care with all what they have. So what happens within these 2 weeks? Is there a way the hospital can treat them and then wait after the 2 weeks now to deduct whatever they deduct from it?
The Honorable Francis Munyao.
Mr. Speaker, I have a concern because we have information that there are some people who are being forced by our staff at the Referral Hospital and other hospitals, of course, to pay cash. And you have threatened, if you're going to actually produce a universal healthcare card, you're not going to be treated. And once you give something small, because the country and the counter has become a little bit dry in court, Mr. Speaker, you are treated very fast. Actually, that is the practice. It's only that you don't want to make a lot of noise here. But Mr. Speaker, can Waziri tell us whether he's aware of that.
Member for Kikumbuli Southward.
Thank you, Honorable Speaker. My question is, if the requester was asking about denial of service because you have not subscribed to the universal card, it means there are allegations which may be substantiated. People may have been denied this service because they were not because of other reasons, yet they had already subscribed. And also on the subscription, because people may be admitted into the hospital. Are you sure that whenever somebody is admitted into the hospital and they are admitted even beyond the 2 weeks, their bills will be paid after the 2 weeks expiry? And on the same note, there are people who don't have the communication. You have not been telling the populace that the 2 weeks is needed for you to subscribe. You need to subscribe. You need to tell them that this is an insurance, and you don't get the service of the insurance if you have not subscribed to that, because you may have put the rules. Maybe this assembly may have put the rules, but you are not implementing the rules. You are not telling the people that they need to be subscribed, because we have met many cases in my ward and other wards. People are not aware that it is not an instant service. You have to be registered 2 weeks prior to when you are supposed to be sick. Or are you failing as a department in executing that? Because the assembly has given you the resources. The people are expecting you to do your job, and you are not telling the population what is expected of them. I also understand within the rules of the UHC, people beyond 65 years are also covered, but only if they have subscribed to the service. Till you get sick, then when you are taken to the hospital, you'll be treated for free. Have you explained you also get sick? Thank you, Honorable Chair.
Member for
card. Waziri, you have said that you did an amendment so that once you pay the card today, it will take 2 weeks. Why did you do the amendment to take 2 weeks as opposed to what the people of Makueni knew the card is supposed to operate? And
Mateso.
Yes, on the Makueni. Kindly, we need to know you have a program for sensitization. Thank you.
Waziri.
Thank you, Mr. Speaker. The changes that happened to the Makueni care happened in October 2021 and went through all the processes, including approval by the his house. This was October 2021.
Answered.
The amount to pay is 1,000 shillings, not 500 shillings. And this is an insurance, so it will be an adverse, selection of clients if you are to allow it to kick in immediately.
Is it in the finance bill?
It is clear.
Finance Act.
Yes.
The charge is provided for in the Finance Act.
Yes.
Which has been processed through public participation, the assembly and assented.
Yes.
Answered. Next.
Then the NHIF does not kick in immediately. If you get the card right now, you will still have to wait for 2 months before that NHIF kicks in. The only time, Mheshimiwa, what you have talked about is probably if you already had the card and you had fallen behind in terms of subscription, that's when probably you can be allowed to pay a penalty, then it kicks in immediately. Our elderly population do not have to wait more than 65 years. They don't have to wait for the 2 weeks.
The elderly don't have to wait, and therefore, what is
Yes, for the elderly.
But remember, I think that matter is
the medical superintendent is whispering to me that we have a situation where some of our citizens actually don't have the documents, the ID cards and the birth certificates, So I think we need to assist them to get these documents because you cannot be enrolled into the systems. When it comes to the few bad apples that I may be having out of the 2,000 people that are under our care, under our supervision, I feel and I would request that we bring them out. Anyone who is found to be soliciting for monies to evade the system, we are not. So this is not to be encouraged, and we will not encourage it.
Member from Lalemale? Yes, I will come to you. Member from Lalemale, what?
Honorable Speaker, I think I want to appreciate those sentiments by the ECM, but it is good to not to preach water and drink wine. This because a patient from my place, a place called Makueni, a lady who was aged 80 years, could not be attended, not even attended. She was not allowed to register for the universal healthcare services, and she was forced to pay money. So what the ECM is saying is good. It's water and take water, not wine. Thank you.
For clarification, and as you ask, Honorable Kalunda, then why register an old person and you don't require them to pay? Why can they produce the ID card? Because what is the difference between registering with Makueni UHC when your ID card reads PO Box Kamunyolo Water and the ID indicates you are 70 years? Should there be a debate at whether to be admitted or not? I think that is the main question. And then if old people require to be registered, is it then not important for the government, whether executive or the assembly, to sensitize so that those old people are assisted to be registered? And then thirdly, if then there is a requirement for 2 weeks grace period for ordinary card to be applicable, have we sensitized our citizens on that change from 0 days to 14 days? Otherwise, they will continue to flock in the hospital. They will continue complaining that they're being denied services, aware that the previous card that had expired was instant. Honorable Kalunda, you want to add on to that?
Thank you, Honorable Speaker. It is still hanging. Yeah? The question is still hanging because I have cases where to benefit from this service free of charge. They were even forced to pay. Sometimes some amounts, like even 25%. And that has been happening. Maybe it changed overnight. It changed from yesterday. Then on the second note, where people, the elderly, do not have the national IDs, sometimes it is good to even vet them because they have neighbors, they have the sub-chiefs. That can really help because the most vulnerable people do not have information. In fact, they don't know what is happening around them. They don't even listen to the radios. Then number three, there is no sensitization. So you just expect people to be aware that the grace period went from 0 minutes to 2 weeks. And nobody is telling them. Then the last one, because that is sensitization and they have not been doing that for all that time. I don't know whether affect those are the issues we also need to know. Then last one, and Kwale, they are taking advantage of the NHIF cover. They are paying for their population, the fundable population. Then that population will take the money into their hospitals. That has been spoken not once, not twice by the minister and also the chief officer. But we have not seen any practical implementation status happening with the county of Makueni. It is better we spend some 100 million shillings on the population, then they bring 200 million shillings. And that way we will have put the hospitals in the right places. So that is something we need to challenge ourselves, including the assembly, so that we can help the population. Asante sana.
Thank you, Mr. Speaker.
Indeed, we are making good speaker. And Waziri
some of them could be sabotage. You know, Mr. Speaker, because it's very, very critical, Mr. Speaker, for that to be handled. They may be doing all the best, but remember, there is transition even within. There are members of staff, like, for example, the CEO, Dr. Ndolo, has been around in the hospital. And there could be some others who look at his size and say, I mean, what are you telling me? So Mr. Speaker, there are those things that we need to look at, because you are doing the best, you know, in good faith, but you find there are others who are pulling you down. So it's something that you need to look at. Now, the issue of the UHC and NHIF, these are two critical facilities, Mr. Speaker. So I would wish maybe Waziri to tell us which way, because as you had heard my colleague here, Deputy Majority Leader, say, it is not that he's joking, it's a fact. Go to Tower Hospital, I mean Tower Health Center. You don't have cash. Perhaps you may be told, you hold on, because it takes a process and all this. I want to say, Mr. Speaker, it's good that we have seen ECM, ICT around. I happen to be a beneficiary of a session on automation. But that is something that is coming. If that automation, Mr. Speaker, will be effected, some of these things, I can assure you, will be over and it will be open. So, Mr. Speaker, those are just some of the sentiments as we move on. And Mr. Speaker, I know we are only on number 4. There are other several questions up to number 15. So, Waziri, prepare. We are around. So don't be in a hurry, and your team. Because we have to address this matter. It is really hurting. I saw the other day on a social media a very long statement in social media talking about deaths, 750 deaths in a day. You know, so these are things that will not be left out. They need to be mentioned by Waziri. Is it true? Are we having all this? And what is happening? How has he addressed this, Mr. Speaker? It's very important. I thank you.
Honorable members, we need to go to the next question. I've listened to Honorable Kalunda, leader of the majority. 90% of your submissions is what you are laying emphasis on what had been raised before. So if your colleague has passed a point, we create time so that you get an opportunity to speak in the next point. I've just received a text here. Someone says is following the proceedings and would want to know what is the age that one is declared hold to access healthcare. I think you can mention. I felt it's important I mentioned that. Honorable Mateso, you want to speak still? Will you make it as small as possible?
It's important to just understand, because they have said that upgrading the ICT, because you see, you've talked of if the system is down, then our patients will not get the services. If we, like, for example, we are using the NHIS. Thank you.
Fair enough. We'll come to that. We'll come to that. I'm careful so that we do not deviate from the questions as asked. And then at the tail end, if you have supplementary information to inform your action point and way forward, that will be important. But in the interim, it's important that we thrash out these issues as they are. Chances are that they're going to inform decisions that we're going to take, corrective or otherwise. Waziri, conclude on the aspect of UHC, NHIF, and remember what Honorable Kalunda said on the UHC local against NHIF.
Members, Mr. Speaker, we are in a changing environment. Even as we discuss the Makueni care, I need to quickly remind you of what happened a few days ago on 20th of October, when the president launched the UHC, program that is going now to run across the whole country. We need to quickly familiarize ourselves with the 4 bills that were signed into law the day before that, and that is going to even restructure the NHIF as we know it. We need to also understand the digital bill that was signed into law by the president, and which is going now to actually guide us on the way forward in terms of taking care of our clients. We were slightly ahead as a county in terms of digitalization, and that's why I had mentioned that we had actually started working on a platform ourselves. So once the national government is actually actualized that, ours will be plug and play. We are ready, and we are ready with the primary care networks that are going to happen. So things will actually change a little bit more drastically in the next few months. I don't know, Mr. Speaker, if you want ICT to make the comment now or a little bit later. She's ready either.
So that we don't affect the flow of the questions. Well, that's why I said, why can't we allow comments by your colleague on ICT, because they seem to be curing the issues. So when you cure before diagnosis, as a doctor, you know there's a problem. So you must take images, you must go, and remember you have a question on imaging and the laboratories and the drug supplies. And I think if automation has to do with the commodities and drugs, there's a question on that which you need to touch on. It will be appropriate if you give us that report.
Well advised.
At the tail bit.
Thank you.
I hope that matter is addressed, honorable members, but the comments of the members have been taken. Your response is taken. We'll put that forward to you. Question number 5. Whether the hospital has a public complaint box or portal, and if yes, provide a list of complaints that have been raised by members of public, patient, staff, and indicate the action taken to address the complaints. Question. Oh, you are on.
If I may, okay, it appears as question 7 on the.
Okay, you are on which question?
It appears as the ones you've read, Mr. Speaker, appears as number 7.
Which question are you ready on?
I'm ready either way. Guide me on the order.
Yeah, we provide the names of the specific chemistry pharmacies where patients have been referred, the purchase of required drugs, and why those specific chemistry pharmacies were chosen.
Mr. Speaker, there is a question that comes before that. I think if you allow, we can have it first, the one on the lack of medical drugs, because that now builds into the next question about the specific chemists.
Is why the hospital lacks medical drugs despite the county assembly having appropriated 288 million for the financial year 2023-2024 budget for purchase and supply of medical drugs. An action taken, the department has taken to ensure provisions of drugs at the hospital is restored.
We have, Mr. Speaker, the department ordered drugs from meds as follows, as highlighted on 16th of June, drugs worth 37,839,000, and then on the 24th of June, drugs worth 72 million shillings. The June order delayed due to stock taking processes at meds, and the deliveries were combined and supplied to all facilities in the county. Makueni County Referral Hospital received their orders from 8th of August 2023, and since then we were actually supplied with sufficient quantities of drugs, including drugs for hypertension, diabetes, and other non-communicable diseases. We have copies of this. Right now we are in the process of doing the next order. This, just to top up on this, for this quarter, this will be delivered in the next 2 weeks to the hospitals.
Is that answered, honorable members? Member for Cascade Ward.
Thank you, Mr. Speaker, sir, for this opportunity. Mr. Speaker, I would like to ask our Waziri. I remember sometimes back we were with our governor at Cascade. It's Sultan Hamid, and we were told that some drugs had disappeared. Same thing applies to Kimakio, whereby the honorable member from that area also caught people carrying the same drugs, stealing them. What action has he taken as far as that is concerned?
Honorable Francis Munyao.
Thank you, Mr. Speaker. Mr. Speaker, my concern is Waziri has told us last consignment that he received was worth 72 million. And he has indicated that in 2 weeks' time, he will have another consignment coming. And would wish to know the cost. Because now there is not, we don't have a lot of outcome.
Thank you, Mr. Speaker. When you go to our chemist down here, you find the people lining up to buy medicine. And
what?
Yeah, when you go to the chemist down there in the market, you find the people buying medicine. And then you ask them, they tell you that they are referred to go and buy the medicine there. If there is enough here, why refer them to the chemist then? If there are enough medicine. Thank you, Mr. Speaker.
Honorable Kaluna.
Thank you, Honorable Speaker. My issue is very simple, and it is also related with other issues within the hospitals, because people are asking themselves, they can't tell when the drugs will be in the hospitals. That's why sometimes people choose not to even go to hospitals, because they will be in the queue since morning, and then much later in the evening, even without having the lunch and dinner and everything, they will be told to go to a nearby chemist to buy those drugs. And it is a common practice all over the place. You've even heard from Honorable Brian saying that we lost a kid just because we were not even able to provide gloves in the theaters. You ask yourselves, why should a hospital have a theater without an X-ray machine, like in Kalawa? In the Kalawa Health Center, they have the...
Hold on there. On the X-ray imaging, there's a subsequent.
Sorry, okay. Yeah, thank you for guiding. Then, no, I'm finishing.
Yeah. Then let us try to be as brief as possible. We are now almost 1:15 midday.
Okay.
So that every other member can get an opportunity.
I will combine my question in the next.
Fair enough. Thank you so much.
Opportunity. Thank you.
Mine is on the same. Probably I would wish the team to respond as to the coincidence. In as much as I agree that medical practitioners can also run businesses in line with their duty, in line with your profession, just like any other profession. But I would want to understand the coincidence in that you go to a medical facility in Kilili and you find that the nurse in the medical facility has an outlet in that market. Maybe a pharmacy, maybe a laboratory or something. You go to a remote place in Vinganzia. You find that the nurse in the facility, in the health facility, as a chemist or a laboratory in Vinganzia. Why not in Miangeni or in Kikumbulu? Thank you.
Elizabeth Mutindikio. Last one.
Thank you, Mr. Speaker. Related to what the Honorable Kimongo is saying, we have information that even if you don't own that particular chemist, if you refer patients to that chemist, you're going to get a tip at the end of the day, because the referral note has a name of the doctor referring. So there's something for that doctor from that pharmacy at the end of the day. Is the Waziri and the CEO aware of that?
Waziri, third question as a supplementary question that was raised to you, which you had responded, why are the patients being transferred specifically to Kaiti Pharmacy, Kako Chemistry, and Makueni Medical Services for purchase of drugs? That was a specific one. Go ahead.
Thank you, Mr. Speaker. We have sufficient commodities, and I think I'm happy with Shimiwa because actually when this came up, a good number of the honorable members went around the facilities in their own areas of jurisdiction, and actually quite a number called me and told me they're happy with the supplies in their facilities. We have to be aware that we have what we call the essential medicine, the list as given by the policy guidelines. So in case occasionally there is one drug which is missing that we are not able to stock, those rare conditions, then you might get a client getting requested to get it from elsewhere. We had an internal audit within ourselves, and we realized sometimes actually the hakuna dawa might actually be because some of our prescribers are not following the exact guidelines as given. For example, instead of writing paracetamol, someone writes by the trade name, and the person in the pharmacy has the paracetamol inside there, and more details, but this committee actually checks on the prescribing habits in amongst our prescribers, and also has powers to basically audit every month and produce notes on the practices. That is in place. It wasn't, and we have since put that in place. We have placed an order. The immediate order that is being processed is for 45 million shillings. This is going to the 15 hospitals that we have across the county. Then there will be a follow-up order. The smaller facilities right now are still quite well stocked. So, but we have made provision for another order to come in the month of November, basically for the level 2s and level 3s. That will make a total of 72 million shillings for this order. The case that Mheshimiwa Masongaleni mentioned is actually undergoing disciplinary action. This was purely someone we have taken through the disciplinary processes, Masimbani. So those are the few isolated cases that we are talking about, the bad apples, and we will handle them through the normal channels that are provided for. Allow me to ask Dr. Ndolo, my chief officer, to respond to one of the comments.
Proceed.
Thank you, Mr. Speaker. I want to respond on the issue of businesses, coincidences of businesses being of medical in nature. This one is regulated by the regulatory bodies, and what I can speak authoritatively today is for the doctors, even the license they have from the medical board allows you only to practice in one facility. For the regulatory bodies of the other professions, they are still not clear about where you can practice. These doctors and the other health workers, they do those practices outside the working hours. And now this is where the thin line comes in. Will you prevent them, given the motivations that have been raised by the majority, when 510 are still sitting waiting for promotion? Do you not tell them they cannot go practice when their regulatory body has not prohibited and they are not eating into our hours? Then the issue of referrals, it is true, we have received not in written form, but through an official channels that it's like there are specific referrals to specific places. And as also it has been mentioned, as we are going through the transition, we have been able to identify some of those creative referrals, including creative shortages and dysfunction in some of our departments. And I want to be categorical to quote the laboratory services at Makueni County Referral Hospital.
there is a time where shortage and out of stock of reagents was order of the day. And we have the lab manager in the gallery up there supporting the superintendent. And I can tell you, as we sit here today, all the tests that that lab can do, in the last 3 months, we have been having those reagents. So actually some of these questions and pressure could also be coming from other quarters. On the issue of ownership, I want to agree with the Honorable Elizabeth. It is true, if you check the ownership, you may not find the health facility, your worker owning it, but then they have that interest of going to practice there when they are free. And is it happening in Makueni only? Mr. Speaker, the answer is no. It's happening in the whole country. So when we have 7 workers per 10,000 population instead of 45, will we be the first county to say they should not even practice when they are free? And if we move that path, what will we be taking this county into? So I would want that to be left to the department and the regulatory bodies. But for the purpose of the commodities, when we receive these reports, we need commission teams which were from the Department of Health Services and the Department of Devolution to comb all chemists in this county, the private chemists. And they went and we received a report and we did not get a single commodity that could be traced to originate from our health facilities. So some of the allegations we have gone to greater length, but we have not been able to substantiate. So my appeal to this assembly is to keep assisting us as you oversight us, the department, also giving us the information which you get from the citizens, so that if there are any malpractices within our workers or within the private facilities, which we duly supervise also, then we can be able to go in and rectify and ensure Makueni citizens get the best services.
Oziri, just to give a rider to what the CEO said, mechanically speaking, not clinically speaking, a very mechanical and simple way, like laying bricks. The subject matter is not private practice outside working hours. Some members of this county assembly operate businesses, are consultants, but they are here. After 5, they will do what they do best. Others will do private practice, who could be farming. That's okay. The question here is doing private business during working hours or using the office to advance the interest of a private business. That conflict, it's as simple as that. A doctor, and who is seated here, the med soup, who is a pediatrician. Now, let me use an example. If this doctor would have a private clinic at Kwakatoka, which is not far away from water, which he operates outside working hours, and that does not contradict the management of the hospital and the working hours, I don't think that is the question. Because those that around Kwakatoka who prefer to be seen by Dr. Kishogo, is it? Who is a pediatrician. But if Dr. Kishogo, for argument's sake, then refers patients from Makueni Referral Hospital to wait for him at his private hospital, that is the case. Or leaving the referral hospital between 8 and 5 or whatever time is required in the hospital and offer his services, that is the complaint. An example was given, I think, is by Honorable Matreso. I don't know who it was who said that someone in the dental unit, is it you, Honorable Matreso? Someone from the dental unit on the floor, it is on record, answered, said that we are not able to do it here in the hospital. So I refer you to a place X in water. So when that patient went to that place X, he went to meet the same person who referred them. Fairly, unfortunately, the matter was sorted in a very nice way. But then it was referred from the same person, from public to private, but the pain could not bear. So he had to deal with the pain and go home instead of complaining about the systems. So Dr. Dolo is not a question about the controls and the systems. It's a question about taking advantage of man hours and the working hours and the instruments for referral. And then too, Honorable Kimongo question is not as to whether a pharmaceutical technologist should operate a chemistry. No. It is that at Ivingazia, for argument's sake, dispensary, the chemistry operating at Ivingazia is owned by the nurse who is operating at Ivingazia. But that nurse doesn't come, for example, it's for argument, we are not referring to Ivingazia, but that nurse could be coming from Tanke. So that chemistry is associated with an officer working in that station, but that officer has no chemistry or facility where they come from at home. Meaning there's a symbiotic relationship between where they are serving and maybe referral of customers or drugs or ABCD. I think it's a same conflict. But then 3, Waziri, you've talked about, I have some little basic knowledge on this practice. Then if the problem is referring patients to chemistry with prescription, like for example, instead of, if what Honorable Mutindi said is true, if paracetamol company X, Panadol, has an interest in selling its commodity, then it will urge me as a clinician to refer patient to the chemistry, and the prescription is Panadol green or blue or yellow. But if you look at the chemical composition of a Panadol, is paracetamol 500 milligrams. But in the hospital, in the tin, there is paracetamol, GOK, not for sale. So the person prescribing do not prescribe paracetamol, which is in the chemistry, dispensing chemistry in the hospital. They prescribe Panadol or Sonadol. But because in the chemist there is no Sonadol and there is no Panadol, but Panadol and paracetamol, the chemical composition, the effect in the body is paracetamol, you end up going to the chemist. That you have controls and measures to know that for a clinician or a doctor to make a referral outside the hospital, then a record is kept against the stores. So that then you can audit at the end of the day, or the medsup or whoever it is, or lab director or the pharmacist or the CEO, to check whether all referrals for drugs were necessary, in that the requisite amoxicillin component in that antibiotic that was given was not in the hospital, and the surgeon said we require this and not this one specifically because of a surgical case. So that then you don't have the ordinary amoxicillin in the hospital and you're being referred to acquire another amoxicillin which is green in color, but it's the same grams, same chemical composition. I think that conflict is the problem, which then it means that the hospital and the lab, or I mean the pharmacy, will have extra stock because you are not consuming, you are not dispensing and referring. So ultimately is a conflict in referring patients for consultation or referring patients for prescription, in which case you have the drugs within the hospital. That is what basically members are raising. But should we not have drugs as you've indicated because of the budget and you've run dry? It is common knowledge that you will communicate, we will have interruption in the month of September 15th to end of it, and then that is understandable that we may not have drugs, which is a question then you can answer substantively on, either delayed supply or lack of budget. That's understood.
Thank you, Mr. Speaker. The conflict where a member of staff is basically spending hours that are meant to be within our facilities, spending them elsewhere, that is definitely conflict, and we will not condone that. There's probably been some inefficiency in some of these supervisions and the enforcement of that. I started by saying that Dr. Ndolo seated here overseeing all these officers is not going to be very efficient. We will need, and we have advertised for a second chief officer who will be specifically in charge of HR and administration. This will help us a lot in enforcing this. The issue of the prescription, as we have outlined, will be easily cured, and actually we have begun to cure this in the hospitals that have automated systems. so that the clinician initiating the prescription is forced by the system to pick from the system what is in stock in the pharmacy, and only a separate prescription is generated at the pharmacy if that particular drug is not completely available or there is no suitable alternative available in the facility. This will even be better cured when we have the automation systems integrated as we are working on with Waziri Elizabeth. Allow me to comment at this point in time that our own staff have been heard saying hawajaiona madawa kama hii kwa hospitali tangu waanze kufanya kazi. One of the reasons is because actually wanaogopa kushika hiyo madawa. Wao wenyewe wamesema hivyo. And one of the main reasons is the system we have, and if you allow Waziri Elizabeth 2-3 minutes, she'll actually talk about the automation we have done to protect and actually have that visibility on the commodities. Even as we sit here, I can tell what is in pharmacy in Kathonzweni just on my laptop, if you allow, Mr. Speaker.
If you allow, I've spared some minutes, concrete, to speak on that automation. And perhaps I know you may make comments on the issues raised by members. They might have provoked your thoughts as ICT on the remedies that we require. So that we just go with the flow and then you pick those issues so that as we conclude, you pick them up, Waziri.
I have a serious concern, and actually, this is related to the question which has been asked by Waziri has been asked whether it is a coincidence that somebody is working at Kilili and he has a dispensary. He has a chemist at Kilili. Is it also a coincidence that a nurse who is working at Matiliko has a chemist at Matiliko? And at the same time, Mr. Speaker, because that is rampant. We come from Makueni, we know what is happening. Mr. Speaker, again, my concern now, the serious concern, is that most of these clinics and most of these chemists, they are not licensed. They operate at night. When you try to go around during the day, they close and run away. At one point, I went to Emali. I want to revert to Emali, and then happened to go to a very popular joint around there, where I go for some medicines when I'm sick. The speaker was told it was closed. Then after some hours during the night, that operator, I don't know whether it's a nurse or what, she opened. And that practice went on for around a week. And then when things cooled down, it is open now 24/7. Mr. Speaker, actually the chemists, nowadays they're operating like kiosks. Yakuza Mira. I'm sorry to say that. So we need to be told whether all those kiosks which are selling drugs in the name of chemists, whether they are licensed, and why do they operate at night only? And are you aware again?
I hear you, Honorable Muso. From where I'm seated, I also have a right to protect the Waziri. The regulatory institutions, because the Farmers and Poisons Board do control licensing of chemistry and the operations. The county government, I think, can only complain or raise an issue. And the county assembly has also a role to directly petition the Pharmacy and Poisons Boards to crack down. It will even be more weightier than the Waziri. But I know that role still lies outside the mandate of Waziri, other than advisory or complaint or something like that, or making recommendations. But there you go. In terms of 1 minute, no. In terms of if you were to take stock of whether all chemists are licensed, that is Farmers and Poisons Board. But the question that you've raised, that in Matiliku there is an health officer posted there and is running that chemistry in that particular locality, ultimately that is as a conflict, because it dots back to referral from compromise of systems from within that particular area, then to the same hospital. Then it follows without saying, for one to operate that chemistry outside the hospital for a period of a year or two, then they are confident that they are likely to be here for the next 4 or 5 years to invest. Meaning then that you have officers who have been stationed on around dispensary or health center X for a period of time such that they are residents, and they will invest not limited to that chemistry, but to an hotel, to other businesses that will distract their attention. I hope Honorable Musa have separated the two. One is within the control of Waziri, the other one is within the control of a governance institute.
I didn't ask because I was ignorant of the fact that they don't license. I asked because I wanted him to tell us whether he's aware or not, and whether that practice should continue.
The question is simpler.
Mr. Speaker, I had mentioned that we actually send a team, my team, round to actually inspect these facilities. As long as they are within the county, the boundaries of the county, I can actually send a team, and this will be done routinely to inspect and see. If they are not licensed, I may not have the powers to close, but if they are not licensed, then I will escalate to the relevant authorities. What Dr. Ndolo mentioned is that when we went around, one of the things we were looking for is, do we have any commodities that have been diverted? And we did not find them in our, in any of those facilities.
Let me get you short.
Yes,
I think what Kibongo is saying, and Honorable Muso, is for Nas Musila to be in assembly dispensary and operating a chemistry outside, they must have served for a period. Whether that chemistry is licensed or not, the fact that they are coexisting across the fence ends up compromising referral even for external services when you have the commodities. I think that is the point.
Mr. Speaker,
and then could there be a possibility that then one has overstayed to an extent of comfort, so that even running chemistry is not a risk, that they are likely to be there to do their business and work at the day and oversee their business. You may not manage one if you are in Mtituande and you're working in Kilungu. I think that is the argument, and therefore that is encouraging that aspect of a business. Whether it is illegal or not, it is compromising the services and the referral systems in the hospital. That is a contentious issue.
Thank you, Mr. Speaker. The law is silent on how far the business should be from the facility that you're actually working in. The other aspect of an officer having overstayed in a particular facility is something we will take up and see how best we can, reorganize our people around. It's a point we have taken note of, and we will see how we can reorganize a few things here and there.
Honorable Mutuku, you answered?
Mr. Speaker, I think what Waziri is telling us is that he has no control of the businesses, whether they are put in the kiosks, whether they are operated by their own staff. Because when he tells us that it is not prescribed in the distance that one should put a business. And here we are saying, and we are complaining, this particular nurse or this particular ex is selling drugs just at the gate of that dispensary or that health center, then it means that, Mr. Speaker, we may not get much from the Waziri. So I think Waziri should commit himself to investigate and actually know whether that is the truth. Because according to us, and according to me in particular, it is the truth.
I have how many members to speak? Member for Honorable, that member is not attentive. I skip. Member for Kakoya.
Thank you, Honorable Speaker. I belong to the Committee of Health, and I just wanted to say something pertaining what is happening, especially with those chemists and all that. In the Bible, in the book of Matthew 6:19, somewhere there, it says that where your treasure is, there is your heart. And Honorable Ndolo talked about the agents in the laboratory. And I just wanted to say that there are some transfers which we are done, especially for the nurses who are manning our dispensaries. And you'll find that person, especially in my ward, in an area called Kaseveni, that person is not attending that, or is not attending the people of Kaseveni dispensary, simply because he says that he's suffering from a chronic asthma, something like that. But the same person was in the same ward, somewhere called, because where the treasure is in Mituvu. So that person is reacting to that transfer so that he can go to Mituvu. No, the whole issue is about the attitude. Even if we say we are going to bring ERP systems since they started working, and the system is good as the users. You have heard even on prescribing the painkillers and all that. Somehow we are sending our patient to go and buy from outside, but we are not depleting or we are not taking the stock of the painkillers which are in our hospitals. Simply because you cannot, even if the system was as good as what, if I don't know so what, when you prescribe Sonadol, that painkiller will remain there even if the system is good as what. So, Mr. Speaker, I just wanted to say, let us handle this matter, are reacting to the changes. If that person has been taken to another branch or to another dispensary and is saying, no, I will not work from here, and he goes and takes papers from elsewhere to say he has this asthma, while he was working in Mituvu, he was very comfortable. Mr. Speaker, there are those reactions which are taking place and the sabotage at large. Thank you.
Now, honorable members, we have in detail dealt with that matter. If you didn't get an opportunity to speak, please will find a way of making that comment in the subsequent question, which is not very far away from that. Honorable members, there is a question of service charter. You will make a comment on service charter. It is either you have it or not. As to whether you implement it, is a question on whether the hospital has been referring patients to private institutional hospitals, laboratory, imaging, pharmacies, and services, and if yes, which are these services that are referred to the hospital? Now, on the cases of pharmacies, Waziri, you've answered. On the cases of lab, wasn't quite. On cases of hospitals, I think you need to. Now, on the cases of imaging, is where the elephant is. In fact, this is what resulted to every member of this house on Monday demanding that you appear the following day. Was around the imaging services and the referral systems. The first one on customer care and management of the patient and the imaging. Go ahead, Waziri.
Thank you, Honorable Speaker. Yes, we have the service charter. We have the overall service charter in the facility, that's the hospital. And then we have, each department actually has its own service charter as you enter the department. So that is in place. Then for the imaging, Mr. Speaker, if you allow me to request that the medical superintendent of Makueni County Referral Hospital imaging requests in the facility. Proceed.
Thank you, Waziri. My name is Dr. Daniel Gishogo, the medical superintendent of the hospital. We have several imaging modalities in the hospital, the X-ray, the ultrasound, and the CT scan. So the requests usually emanate from the clinicians or even from external referred clients. So when they come to the hospital, they are seen by the clinicians or the doctors, and the requests are made. The requests, whatever they have been sent for is billed, and then they go for the imaging. So when they are there, it is done. For the X-ray, the clinicians and the doctors are able to report by themselves. For the ultrasound, we have officers who can do the ultrasounds. The CT scan is the one that we also have an external person contracted to do for us the reporting. The CT scan is done in the facility, but the reporting is done by someone who is subcontracted, pre-qualified to report for us. Yeah, thank you.
Thank you, Waziri. But basically, it's about how the question is framed. The image for excess, which are these services that are referred, and which hospital are these services referred to? That is just simple as that.
We have, as Mr. Speaker, as in the supplementary question that we responded to, we gave the contracted service providers for the various services. One for pathology, that is the tissue that requires a pathologist. We have Lancet Kenya Laboratories, and we have Diagnostic and Medical Legal Laboratories. For radiology and imaging reporting, this includes now the CT scan. We have Machakos Imaging Center. And then for cardiology services, including ECG and echo, these are matters to do with the heart, physically, not otherwise. We have Machakos Cardiology Evaluation Center. So these are the pre-qualified, basically the subcontracted providers.
Thank you. Thank you, Mheshimiwa Mutia.
Thank you, Mr. Speaker. Mr. Speaker, I would wish to ask the Minister, at the level where we are, having done now should be around 11 years of devolution. Of course, the Referral Hospital was there even before devolution. Should we still be talking about referring some of these cases? Because I want to believe at this level, what is being done by Machakos Image Center, it can be done by the Referral Hospital. Makueni people, we have qualified doctors. In fact, I met a doctor who was working with us at the Referral Hospital, and I think he has left to look for greener pastures because he felt that the services were not being utilized properly. I don't know whether it is the wage or the payment and the salary and all that. But I believe that in Makueni, we have qualified doctors in every profession. And it is the high time we started thinking about equipping our referral hospital so that we don't now keep on referring, our patients to outside consultants because they are very expensive. When they go outside, the payment that we do there, it is, exorbitant. Thank you.
So what is the question?
Is it not the right time, Mr. Speaker, that the minister makes an appeal? Because this is a very good forum, Mr. Speaker, for the minister to make a plea to this assembly. It is the same assembly that passes budgets. It is the same assembly, Mr. Speaker, that talks with the governor directly as far as his manifesto is concerned. And in the manifesto of the governor, Mr. Speaker, he talked extensively about health and ensuring that we have these equipments that are found in other hospitals, in our referral hospital, so that when we are doing budget, Mr. Speaker, we can factor some of the issues that will have gone into record in this forum. Thank you.
Okay. Let me set the base. Ozzy, let me tell you why you're here. You're here because when I was chairing the plenary, more than 10 members made statements indicating that, in actual fact, you're far much better referred from Makindu or Tawa directly to the imaging center, because after you're referred to the referral hospital, you will end up being referred again to the imaging center. So all imaging services are referred to the Machakos imaging, and I do not know for this debate, is Machakos the so-called Doctors Plaza? For clarity first, so that we understand what is Machakos Imaging. Is it the one opposite the hospital?
Thank you, Mr. Speaker. Machakos Imaging is in Machakos, but they have a branch in Makueni at the Doctors Plaza.
Fair enough. So Machakos, when one refers at Doctors Plaza place, it is the imaging that is in that premises.
Yes, but from the response that we have, what we refer there on routine basis,
there was a misunderstanding when members were debating. Is saying that you have indicated that you have an engagement with Machakos Imaging Center or whatever the name, but it is not done at Machakos. It is done at Doctors Plaza. So we wanted to know whether the Machakos Imaging has a branch in Makueni and therefore it is Machakos, which is at Doctors Plaza's place. Is it the same station? Is that the station?
It is the same, Mr. Speaker, but it is the reporting. It is not doing the tests.
No, we want to understand. I don't know, it's a simple question. We want just to understand the geography. That whether the branch, the Machakos Imaging Center as a branch for whatever services, whether private or referred, next to the Doctors Plaza or thereabout, it is the same.
Yes.
So when one says Doctors Plaza Imaging and Machakos, we are meaning one of the same for purposes of this debate.
Yes, Mr. Speaker.
Thank you. So the argument was that every imaging service that you will seek from the hospital, you will end up referred to the Doctors Plaza Imaging, which is the Machakos, notwithstanding the services that you've referred into, and that have been said by the doctor, the medsup. So that's a big question, and notwithstanding that the facility hospital has the equipment. That was the debate. I'm just reporting what was said. And before you respond, I can see now they're flowing. Allow me to give about how many are they? 1, 2, 3, 4, 5. Please don't request if you're not requested.
If I could clarify, maybe I can answer some of them.
Oh, you clarify. Go ahead.
I feel so. Mr. Speaker, the CT scan machine that we have in Makueni County Referral Hospital was procured under the MES program, the national program, if you remember, in 2016. So it was still under contract up until just recently. So we are in a gray zone in terms of the service, but the service has since, the contract has since lapsed. This was basically under the national government. So we have one machine. Anytime it has a challenge like it has right now, then we are not able to do the CT scans in the facility. So any client who is requiring a CT scan in MCRH has to get it from elsewhere. And Machakos Imaging is what we have in Wate at the moment. So we have engaged basically service provider to repair the machine. As soon as it's back, then we'll continue to do through and through.
I'm curious because now, why are we referring our patients to Machakos? Is it that we are also getting kickbacks when we refer those patients to that specific center? Because it just, if you get the comments from honorable members about the medicine. Now, when it comes to the issue of scans, then we have a specific center where our patients are being referred to, is it also the case that we are, as we refer them there, our medics also get something from the same center?
Actually, the patient should not pay.
Thank you.
Honorable Elizabeth Mutindi, your advocate has spoken for you. Nevertheless, you have the right to represent yourself.
Thank you. I want to thank the advocate for highlighting the matter. But there's something what Waziri has said, that the machine was bought under contract with the national government. I've not really understood what that means. Does it mean that there were conditions that they are not able to source somebody to do the reporting on our behalf? Was it a condition, or did they find it simpler and cheaper for the government to outsource someone to do the reporting? Secondly, Mr. Speaker, what was alleged, what I alleged, as Honorable Katumo has said, regarding these pharmacies and chemists, we also have information. Mr. Speaker, I wish I will not be crucified with what I'm saying today, but we have information that even I was going to ask the ECM and the CEO if they are aware that the scan right now is not in use. Mr. Speaker, this scanner goes bad. Sometimes it's by accident, but sometimes it's not by default, it's by design, Mr. Speaker, so that we can have our patients sent to imaging center where a specific patient will be taken by a specific ambulance with a specific nurse, referred there by a specific doctor who will all of them will get something at the end of the day. Mr. Speaker, when I am saying this in confidence, so let us not hide our heads in the sand, or if maybe the department leadership does not know, they need to go and find out. Sometimes the machine is fine, but somebody decides that now it has to break down so that we can earn something. It boils down to the demotivation that we were talking about. These people need to find some money in one way or the other. So I want to understand why the reporting has to be done. If it was part of the contract, maybe we would understand. How much are we talking about when we outsource somebody to do the reporting versus when we have our own personnel reading those images and interpreting them, who are employed by when the scanner breaks down. Now there is that other case of a doctor now sending a specific ambulance to that specific place to do. And Maku, the report, if the facility is contracted to do that for us, they are paid. So our patients should not be paying twice for the same services, Mr. Speaker. So can the ECM and CEO explain if they know, if they are aware? If they are not, they may need to find out what exactly is going on surrounding the scanning section. Thank you, Mr. Speaker.
Another clarification here first. One, to allow members to give their contributions. If we do not have a radiologist, it means then the scan is taken at the hospital, correct?
Yes.
So, but it's through computers and mails and whatever, or a disk is taken to a radiologist online, whichever means to Machakos imaging. Then someone reports at whose cost? At the cost of patient or at the cost of county government?
The agreed cost, basically the money is paid at the county hospital. And then now, eventually, the agreed cost per reporting is 2,000 shillings. So the money is paid in the county hospital. So this is now eventually.
Just a minute.
Yes.
It doesn't matter whether it's paid, whether through M-Pesa, MasterCard, Visa, MCD. It is presumed that if we had a radiologist in the hospital, that scan will be reported by a Makueni County Referral or Makueni County Government radiologist, a doctor.
True.
And then there will be, other than the UHC or NHIF or Makueni Care, whatever card in form of insurance, then as a patient, I will not need to pay for reporting, correct?
True.
An ideal situation. In the absence of that, then if it is contracted, it means then that now that we have not hired a radiologist, the county government, then we outsource that service.
Yes.
At the cost of the patient will incur, county government will pay the imaging center, because the essence of contracted, it is that it is a county government that will bear the costs of a service that they could not offer, and therefore it has been contracted. So which is which?
The total cost is what is in the finance bill. So the patient does not pay.
So what is in the finance bill? That the cost of reporting a CT scan is, let us assume our CT scan is working. What would be a cost? You may allow the doctor to interject directly on your behalf if you wish.
The CT scan depends on the region of the body. For example, a head CT scan is 7,000 shillings.
Yes.
So that's what the
patient is in the finance bill.
Yes.
So, in ordinary circumstances, CT scan will never be free. That's what you're saying. Assuming that our machines are working, we have an extra cost outside the UHC card and NHF and so forth. If I was to pay directly, is that the case?
Outside the UHC card. UHC card, I said at the beginning, has limitations as stipulated in the law itself.
The services that are free or that you don't pay, the others that you must pay for.
Yes.
Like when you go to theater, there are implants that one must pay because they are not provided for in our health financing.
Yes.
As a county government.
Yes.
So to what extent is a CT scan covered in our health financing as a county government? If we were to offer that service at a cost or at a zero cost?
At a cost.
Depending on the condition.
At a cost.
At a cost. So it is this cost that the patient, instead of paying imaging directly, will pay the same cost at the hospital.
At the hospital.
And then the hospital will pay the imaging center. So you're only transferring the cash.
Yes.
And outsourcing the service.
Yes.
So that is a clarification. And then number two, then the other issue is who then facilitates an hospital, a patient from our hospital to the imaging center in terms of an immobile patient who cannot move? Is it our ambulances or patients who will facilitate themselves to that place? Because that has been a challenge where a patient has to recollect themselves. You look for means, a private means, then you are wheeled there, you come back, you produce, then the treatment plan plans. That's another question. And then number three, because that is a point of diversion, because members will feel that there's a mixture of services between county and the national. It is presumed when you go to the hospital and the county government hospital refers you to another entity, it has since taken over the facilitation process other than that aspect of paying. Then three was, if there are services that we are not offering as a county government, it means then you can only refer to the private entity that offering that service. An image that we are not offering at all, and that we do not have an equipment, like you said in Lancet and any other. Meaning that outrightly you'll get to the hospital, you'll be referred, we don't offer this service, you can only get it at Machakos, you cannot get Nairobi, you cannot get Kenyatta and ABCD. Is that the case?
If I may take just the last one, and I'll request that Dr. Gishogo takes us through the journey of the imaging. For the oncology, for example, and just to mention that we have actually 2 doctors in training in pathology. One of them is coming back. Is it in March? Yes. So we are expecting them next year to finish their specialty training and come back and offer these pathology services now in-house, the same way we are recruiting a radiologist to basically be in-house. So for that specialized service, for example, if it's histology, what we try to do is make it easier for the client. Instead of sending the client all the way to Nairobi, we are able to take the specimen ourselves and transport that specimen through our systems. We have engaged basically some partner who assists us with this. It's a specimen which will go to Nairobi to Lancet, and the report will come back online. So we have actually put in systems to make it very easy for our clients not really to go all the way to Nairobi to seek the specialized services. It would actually be more costly, more time consuming for them. Then the same way we are in Makueni, and even as Dr. Gishogo answers the question about the radiology, we only have one place available in this town for CT scans outside our facility. If you look at our CIDP 3, it has captured the elevation of MCRH to a specialist hospital, basically referral hospital, as it should be. So we have outlined oncology services, we have outlined enhancement of the radiology services, including an MRI that should actually be in place in this facility as it is 10 years, 11 years down the line, as Weshmewa Mutia was asking. So we will be coming and requesting that we put in money to actually purchase another, CT scan machine and an MRI machine. I think a good number was understand because we have had clients referred outside. Then even now get to engage a cardiologist for the third category that was asked for. Dr. Gishogo, take us through the journey. Once it's made, decision has been made and the machine is not functioning and the client is not mobile, because the one who is mobile will just walk there.
Wait, Honorable Mateso, I hear you. I don't know between you and the Daktari will come first. It's always better when you allow the, yes. It's always, Daktari, Waziri, it's always good to allow the raw data to land. But then let us, you can collate that data and make one answer for it. You will answer, the presenter will still want to present. So let us allow, I think there are only 3 members who want to speak, starting with the Honorable James Kalunda, followed by Honorable Mbindio and Honorable Mateso. Make it brief.
Yeah, thank you, Honorable Speaker. I'll be very brief. It's about, because we have the complaints from the citizens. I heard the minister speak of 2,000 shillings, yet sometimes I contribute to a tune of 10, 15,000. Sometimes you are told 25,000. You are doing the scan. What is the, because I don't understand the framework you are using to dictate how much the client, and also the client is being sent to a private clinic or a private premise where they are getting that service. What is the rationale you are using to even dictate how much the client is being charged? Then 2, we have seen a deliberate action by the officers at the referral hospital where they want to send people to those private clinics, and that's why. Then secondly, that charge hospital or private clinic, why don't you just employ somebody who can be reporting for you? Because I understand sometimes they go with the disc and they are given the reports. Sometimes you are told it is a specific person, yet you can still acquire the services of that person and then does the same for the county. On another note, if you are pre-qualifying,
please summarize.
A private, yes, thank you, Honorable Chair. If you are pre-qualifying, it should be, the pre-qualification should be the cost going to the county, not to the citizens, because the citizens are crying all over the place. Even in my ward, I had to put monies to do the implants because I'm doing RMBs every day. I'm spending a lot of money on these things. So if it is easy for the citizens, it is easy for the minister and also the county assembly. So why don't you work on a plan to make it easy for everybody so that even the governor can get the votes very easily in 2027? Because as we are not looking at the service delivery in terms of your parameters from the school, the medical school, we are looking at how we can get the votes. If you are not able to amass the vote for us, we are not reading from the same scriptures. Asante sana, Speaker.
Okay, you have said so many things, but you have qualified with one statement. Since from morning, you would have started a search that whatever we discuss here must relate to your welfare and the welfare of your people. So it's up to Waziri to align. So, fair enough. Honorable Mateso, and then Honorable Mindio, then Honorable Chalabuma. Honorable Video.
Yeah, Mr. Speaker, I wish the doctor now gives us a time frame when this machine can be repaired, because we can keep on seeing about the machine is broken until the year ends. So it is important that he gives us a time frame.
Fair enough, Mwalimu.
Thank you, Mr. Speaker.
Very good, Mwalimu. A retired teacher. Once a teacher, always a teacher. Honorable Mateso.
Yes, Mr. Speaker, it's good. It is a lot of business today. And Mr. Speaker, we are of this. Then we think otherwise. Number two, our people are spending very costly on these specialized image services. Very costly. Even ourselves, to an extent of even deep in our pockets and helping our people. And my findings that I want to offer to this house is that this could be a scheme of business. This could be a conduit from our referral hospitals to these contracted institutions. A conduit of making business. Because if Waziri, you are heading a flock of over 2,000 staff, you may not know what happens behind your back. And the reason for saying this is because I had actually a patient who was referred from Makindu to Makueni referral. You can imagine Makindu, the level of Makindu and Makueni. And she actually stayed there for like 2 days. And then the patient was referred to Doctor's Plaza for an image. Then you wonder, why was he not referred from Makindu all the way to Doctor's Plaza? He's stationed here, then later he's taken to Doctor's Plaza. And the amount of money that they are talking about is a lot of money. You look at the status of that patient and then you wonder, where will he get this money? People have sold even their pieces of land to pay those images down there. That is what is happening. And the truth be told, that is what is happening. People have spent a lot on this. I don't know. And sometimes you don't know where after the images are read, where the reports ends up to. Because some of them die, they cannot afford medication, and that is what is happening. Kindly. And when you say that a CT machine is down, you are not telling us any plans to repair it, then it tells you that it will just remain down completely, because the conduit must continue contributing to the business. So, honestly, we need to know what is happening. If it is business,
let us be told it is business. If it is not business, let us see these services be given to our people the way they should. You know, we are people not sometimes who normally go to church. And like me, I say, 10 years leading the people of Watazu ward. One time I will be in heaven and God will ask me, what did you do to these people for the last 10 years? The same will be even asked to those staff who are just giving services to our people. So let us fear God sometimes. We need to fear God. So, me, what I can say is that it is important, actually, we just go to the root cause of this issue so that our people can, at least, we can save them because they are waiting, depending on us. And you remember, the slogan I quote, one must work. And the Olungali itself must be there for us to survive as politicians, because the Olungali itself, if it's not happening, then I don't think then we will go far. So thank you, Mr. Speaker. That is, I rest my case.
Honorable Chalamumo.
Thank you, Mr. Speaker. Mr. Speaker, I truly want to appreciate the contributions from the honorable members and also from the Waziri and his team. You know, Mr. Speaker, this oversight has come on a time when tomorrow, 26th, we are having something called World Hospice and Palliative Care Day. Perhaps Waziri will tell us what that is, because I don't know, and for our people to understand what it is. Mr. Speaker, I am just wondering, this referral, you know, everybody from every health center is referred to what? I mean, to Makueni County Referral Hospital. Why referral? And then when you come to the referral, you are referred to somewhere else. And when you go to that somewhere else, you also referred. So I didn't want to understand that referral, what it means, because it may have lost the meaning, Waziri. Because indeed, if it is a referral hospital, let it remain so. Waziri, I remember because I was in that committee that made that appointment, and you told us you left room 302 in Nairobi Hospital to come to Makueni. Of course, you are facing challenges. Some people still don't believe that you are the same person. You will face those challenges that members have spoken here, as much as you are trying. So that referral, please let us understand that referral, because it has lost meaning, honestly speaking. The issue of the staff not being motivated, the issue of the staff attitude. Mr. Speaker, I would perhaps give an opinion or advice that we may have some doctors, so to speak, in quotes, because you've said not all of them came through County Public Service Board. Maybe they came through other ways. We may have, you know, there was a lawyer the other day who is doing cases in court, Mr. Speaker. And then when there was an audit, this is not a lawyer, but he has won cases. So we may have some doctors who have been operating our people here, but they are healed by God. So we need to know whether we have the correct people, Mr. Speaker, out of these 2,000. We need to, Mr. Speaker, because of this clarion call by His Excellency the Governor, yes, there could be that wawni. But when we let people and we politicize what is happening there, we lose it all. For example, Mr. Speaker, and this has not been reacted to, we have seen that the issue of mortality rate is far too much. I saw 750 every day. I still want to confirm whether this is true, because we have now the chance. We are, by the way, for your information, on YouTube, WhatsApp, Facebook. The other one is what? Twitter. I have seen Honorable Muso here watching elsewhere. So you are live everywhere. Right? So it's important you make that clear, so that the people of Makueni can know that some of these are just politics, and we should keep politics out of the health. Because if we involve politics, Mr. Speaker, we are going to lose it all. Let us face facts. Let us, Mr. Speaker, give our people hope and ensure that we get the services, Mr. Speaker, that all people need. I know maybe soon the issue of the modality, is it model hospitals that are in the offing and that are somewhere? Maybe you will make a comment, Waziri. So Mr. Speaker, I thought those few remarks will be reacted on. I know the issue of promotions. The doctors who are in the union, I don't know that Dr. Mutunga, you are part of that. There's a team that came and they really were saying that they are going to adhere to outside. But we told them that this matter is being addressed because the County Public Service Board is really frustrating. Not only you, but everybody. Thank you.
You've heard that matter. In fact, it was a serious debate. And I think Chalohumo, as leader majority, has summarized. The question is, why should a referral refer and not to Kenyatta? The concept of referral is that you must cap some services at the county headquarters, other than that which is reasonably allowed to be referred to, not from within the county to some extent, unless it's justified so, or unless the machine breaks down for a day or two. So that's a big challenge.
Thank you, Mr. Speaker. Yes, as I mentioned, when we came in the Waoni government, we actually quickly realized that we need to put in some measures into the MCRH, and this is why we quickly captured it in our CIDP3, as I mentioned, that we have actually to elevate it to become a proper referral facility.
Sergeant at Arms, can you correct the microphone? I don't know what's the problem, but that must be sorted.
Thank you. This requires resources. The CT scan machine that we have was procured, Dr. Gishogo, 2017. It's more than, basically we are talking about more than 6 years old. With the machines, as you know, as the year's age is more than 6 years old, at its age, then, it runs into the bit of trouble here and there, so it requires servicing more frequent. There are some resources towards the purchase of a second machine. The issue of an MRI is something I had mentioned a few minutes ago, that we actually need even the someone needs an habilitation when we also have the machine running, because it's a specialized, kind of service. So we will be putting forward a proposal to this cabinet and to this house that we purchase this equipment and make our referral hospital a proper referral. The issue of the radiologist, I think it must have skipped Mheshimiwa Kalunda. We have advertised for this, and we will be recruiting one. The union, we have met the union severally, and actually from our meetings, I think you noticed that we have managed to advertise for the promotion of the 510 officers, actually more than 510. Because we also have the senior ones. And I may mention something at that point. There is some of our senior doctors or other senior officers who are stagnating because they needed to go through some specialized management courses especially the Kenya School of Government. We have since negotiated with the Kenya School of Government on we have met the unions. We are also meeting the Kenya National Union of Nurses because they have asked to have us sign a CBA with them. But this is an ongoing, negotiation with the nurses. The word hospice palliative means basically you are treating these
have the capacity for Makueni to Kenyatta Street on, because it means
hospice palliative means basically you are treating these
have the capacity for Makueni to Kenyatta Street on, because it means that you do not have, but you may have a formula to resolve the problem, because the problem may be bigger than Waziri, may require cabinet attention, may require cooperation, may require MOU, and so forth. So that whatever decision you will make out of this sitting, which has taken more than 3 hours, then we produce programs and policies that are implementable to resolve the subject matter. In concretizing that, as your officers deal with that, I mean, help you to respond on some technical bits.
Mr. Speaker, we have done a quick consult amongst ourselves, and if you give us 30 days from today, we can have a proposal completely costed that will basically be tabled for consideration in terms of moving the Makueni County Referral Hospital to where it should be.
Fair enough. Chairperson?
As I've said,
come up again.
Honorable members have raised an issue which cannot just be left unanswered. Either it will be investigated or what you find. Because I've said the CT scan, is it purposely that it could be switched off for people to be referred elsewhere? Is there such a thing happening? Because if such a thing happens, that's an integrity issue. And we cannot just dismiss it. We need to hear a commitment from the Waziri that you will investigate that. And if there is such a thing, such members will be put to book because we're carrying a lot. If there is such an issue, that our people could be really, a machine can be switched and they are sent for private, that person should not be working with Makueni County. And Mr. Speaker, I'd wish that it is investigated and report given so that we can have a way forward on that.
Felix.
Thank you, Mr. Speaker. Mr. Speaker, for us to actualize the manifesto of the governor and our manifestos as well, and to actualize the dream of one no longer I quote, this should be the thread. We must make sure that we give the services required. Let the business of service delivery be our business. Thank you, Mr. Speaker.
Honorable Elizabeth Mutindi is born in Wate, a school from Munwa. Why she has a lot of information is because most of patients are friends of his family, and that majority of officers and junior officers, they were in school together, so she gets direct feedback. Even when some are not promoted, they report to her. And the Wiper Party nominated her to take care of those things around the town. So don't look for the source. The source is original, and she doesn't look for the information. Information finds her from the childhood networks. Go ahead.
Thank you for that very necessary clarification, Mr. Speaker. Mr. Speaker, as we conclude, I want the House to know that I have a lot of confidence in the two ECMs, in the two medics before us, Honorable Dr. Musila and Dr. Ndolo, who has been long serving in that department. And we want to just...
Honorable Mutindi, we have 3 doctors.
Sorry, even the med soup is a doctor, sorry. Dr. Musau.
So be careful. Be careful. He is a pediatrician, and I don't think you have retired. It's not.
Once a doctor, always a doctor. Just I will always be a teacher. I believe he is Mr. Musau, Dr. Musau.
Dr. Kishogo. Dr. Kishogo.
Sorry. Sorry, I thought
is on the far left.
I was not here when
Dr.
the introduction was being done. I'm sorry about that.
Yeah, that is it.
Yeah, so I happen to know the two. I was not. I am not personally known to Dr. Gishoko. So we want not to be able. We want to stop. We want to stop. Abusing their privacy with phone calls, because when I go and get stuck in hospital, I will call either the CEO or the doctor, because I don't know most of the people. When my patient gets stuck, I think they can bear with me witness that I've been disturbing them with calls. We don't want to disturb them with calls when they have so much work to do ahead of them. So the things that are raised here, it's because members of the public are raising them. Mr. Honorable Mateso is raising things that have been raised by the public. Even myself, I have had stuff from the public. All these members, when they bring statements here, it is because the public is pushing them to do so. So when we grill them here, we want to help them to perform, for their departments to perform, so that they are not recalled here to be told that they have not performed as per their contracts. So we know that they are able to do it, but there is something within the department that is causing all this outcry, Mr. Speaker. So I want them to just go back to the department and streamline issues, because there is a problem within the department. There is a problem, and that problem is spiraling down to Mwenende. And if it spirals to Mwenende, this house will not be business as usual. And you know, we cannot call every doctor to this chamber to ask them questions. So it is in good faith, and we want the best for our people. So as I finish, because I think you said we conclude, Mr. Speaker, I heard that they want to buy 2 ambulances, Mr. Speaker. There have been outcries that ambulances are grounded. I don't know if it is very, maybe they have done their priorities already, but the members of the public are wondering. These ambulances that have already been there, sometimes you call and there's no fuel, it's grounded. I don't know if it is very important to buy the ambulances more than we need the doctors at night to attend to our patients, because we find them hata wakigongwa na matatu huko kwa barabara, the matatu brings them to the hospital. Most of the time we may not even use the ambulance, more than we need to find the doctor on site to help us immediately. So Mr. Speaker, they may need to check. Let it not be an issue of nini na ile inatusaidia zaidi, we do that. Thank you, Mr. Speaker.
Honorable members, Honorable Kalunda, you reserve your contribution. Honorable Justice Mwanzia, I'll give you an opportunity. Honorable Mwanya, you are my deputy. I'm not sure that to give you an opportunity. Honorable Manzu, proceed. You have not spoken. Be brief. Be brief.
Why? Thank you, Mr. Speaker. And I would like to be very sincere with my friend, the ECM, on health matters. The easiest way to do away to finish a politician is to always say to them that all is well. And if actually this house has friends to the ECM, they should have told him all is not well. And if it is to blame, I will not look at any other person. He is a person in charge. I don't know when he heard of these issues of go slow, how many times he has been on the spot. I have spot checks in the Referral hospital. And he should also monitor why the jam is too much in the Referral hospital. Mr. Speaker, I understand that if we have issues with our dispensaries, that jam will come up to the health facilities that are above the dispensary, and it will come until it reaches the Referral hospital. So if we have to get enough cure, and the best cure for this issue, health issues, we have to start with the dispensaries. We need to have staffing in the dispensary, equipping, and then proper monitoring, because I have noted that the Waziri might be a person of who means what he says. And when he talks to his juniors, he just assumes that they will do what he has said. So it is wise for the Waziri to take charge, proper charge of the department, and we know he is the one who is responsible for anything. And I am not sure I will take it anymore when my people are suffering. Let Waziri take charge, full charge and control of the department. Thank you, Speaker.
Member for Kimakigo Lanzaro.
Thank you, Chair.
Brief.
My attention has been brought by Honorable Elizabeth when she compared the ambulances with the medic people. ambulances are equally important as well as the personnel, because like Kilome sub-county, we don't have any ambulance. The ambulance that was at Sultan was involved in an accident. As the people of Mombasa Road, you know, we are in a critical area whereby we've got accidents and other issues. A person called last week and they needed an ambulance services. The ambulance was not there. 2 days later, the person passed on. So when you are prioritizing ambulances, ensure Mombasa Road, especially Kilome sub-county, we've got an ambulance, because when we are
Hold on, members. The
Kilome sub-county, that I've been very specific, Kilome sub-county, because we don't have an ambulance. The other day I witnessed an accident down in Salama. We had to get an ambulance from Machakos County. Quite unfortunate. So let the department, Waziri and the CEO be on top of things, ensure we've got an ambulance in Kilome sub-county. Thank you.
Waziri, there are comments and questions that have been raised. I've received the conduct of assembly business is an open manner, and therefore I can't stop the public from sending a text. I have a text here. What strategy has the department put in place to reduce the walk-in clients at the referral hospital? I don't know what that means, but that's a direct question from a citizen who is following up. And two, there is another one which had come in earlier. It seems to confirm what Honorable Francis Muya was saying. And it says that the prescribers are compromised by medical reps to prescribe by use of trade names. And in the pharmacy, but some clinical officers prescribe and give business to manufacturer names or something like that. You know what that means. There's a text. There's another text. The speaker, note that most of nurses have opened pharmacies near the places of work and complain, and they compromise the authority to transfer to remain in the same area. They are also having their briefcase drugs, wanauzia patient akikosa dawa kwa dispensary. So someone has some medicine in his pocket. But yes, that is it. That's the feedback that I could give you. Those points, I think they've been spoken before. I wouldn't have gone without just mentioning them because they could be watching.
Yes, Mr. Speaker, I accept the question about reducing walk-in clients. Allow me to capture this in the report that I requested that we do within the next 30 days. Basically, this means enhancing services in the satellite facilities. For example, Matiliku, Kilala, Katonzweni, Ivo, then they're able to sort out a number of these clients who should actually not be walking into the casualty. And we will capture that in that report, which will avail in the next 30 days. I want to promise that we will crack down on any of our officers who are actually found to be engaging in the monkey business, basically bordering on criminal activities, if any, especially on the machines that we have in our facilities. So, Mheshimiwa Mbalu, that is taken seriously, and I will actually take it up personally. If we find any officer, we will investigate and we will deal with any officer found mishandling our equipment, either deliberately, actually, or even just through negligence. I think we had spoken about the issues of the med-reps and Mheshimiwa, we have our newest ambulance is actually stationed at Sultan Ahmad.
Fair enough, answered.
The newest ambulance that we have.
Along Mombasa Road?
Yes.
Fair enough. You're done?
Yes.
Very well. Now, we have two more questions that require one intervention. There's a question on health facility management committees. It was responded, but a number of members raised issues, including Honorable Kalunda. I will allow the request of the statement to seek the clarification that was specific as raised by members. Don't go to the details. The rest was answered. The ECM get details more than you are expecting. What is it that was picked? Very briefly.
Thank you, Honorable Speaker. Honorable Speaker, I think, of course, I will be very brief. One, I want to thank the ECM and department. At least they are accepting that there are a lot of errors, whether intentional or non-intentional, in the department. And it is quite evident that 3 facilities were not gazetted out of the 240-something facilities. He has admitted that there was change of names in over 23 facilities across the county. Although there might be some more, because members also are complaining that more facilities have not been captured, including that one from Honorable Kalunda's ward in Kalungu. More importantly, as I appreciate the legal framework that the department dwells on to establish those committees, there is the mechanism that they use or they go through. After the elections were made some months ago, that report or resolution of the public, including capturing of that appointed by the ECM, was circulated across the wards or the counties. And to be precise, in Emali Mulala ward, which has 7 facilities, only 2 facilities, the chairs of those facilities, that is Matiku Health Dispensary and Masangombe dispensaries, the chairs as captured in that document were retained. The others were changed. And when information goes viral to the public, then there raise some concerns. So I wish maybe the ECM will check on that and ensure that as it was captured then and circulated by a government officer, the ward admin who participated greatly in that exercise, it will be as such. 2, there is the issue of, and I want to thank the CEO. He talked about financial constraints, which is true, because money is a scarce resource.
Member of Mali.
Yes, Honorable Speaker.
We deliberated this matter, and
allow me 1 minute to summarize.
8% was satisfied, except aspects that you raised on what happened to the change of names, who was responsible, action taken, why gazette at the expense of the county government, and so forth, so that we create room for Mboni.
Oh, thank you.
Yes, for Mboni Isolation Center.
Actually, that's why I was coming, Honorable Speaker, that someone must take responsibility. In all these errors, because they are saying they are errors, the gazettement has some cost, of course. And because we are saying it is erroneous, which to me and it should be by design, the cost of gazettement that which it's a repeat. Because of that integrity and value for money, I think the ECM must commit to have that someone must take responsibility, because we must utilize public resources prudently. As the CEO is saying, money is scarce resource. Then the little we have, we must utilize it properly to ensure that there is no misuse. And I wish not to state much, but the ECM, based on those legal frameworks and the mechanisms used to establish those chairs, because there must be a mechanism, and that's where there was a list from the department. We wish to those names are recaptured as they were, because I understand that there was a communication between the department and the ECM, and that's why there are 2 chairs captured as it were then, but there are changes of the other 5 names. Remember, to cite example in Emali Mulala, where the chair who is the chair, is one of the person who misused public resources. The TETHECA program is one of the person whose committee never paid anything. Because if we talk about management experiences, then it is be as such. Someone must have positive managerial skills.
Conclude.
As stated in the RIGO document. Because it's not just management, but someone with successful stories of management. That person misused monies for the TETHECA fund. That person was part of the cartels. I'm sure that the ECM is aware that a Mali level 4 hospital now approved the level 4 hospital by the assembly and is promised to be gazetted soon. It lacked water for 2 months. And that man who is purported to be the chair of the committee was part of the cartels, the water cartels. So that brought public cries.
You've made your point.
Thank you, Honorable Speaker. But we could have said much. It's on that we don't have time.
I will allow your colleague.
Consider this push from the public who we represent. It is not our issues. Thank you.
Honorable member, we are 10 minutes to 2. I don't have a problem to sit here up to 2:30 and sneak at the door on my light, change and resume, but I'm sure you will not be here. Not you, I will not get quorum for 2:30, so I'm trying to take care of that. Bugalunda, on that matter, and you have to be very specific, just state what you stated last time. Please don't narrate. Just state.
Thank you, Honorable Speaker. I have seen the response. And some of my facilities are not captured in this. And we talked with the CEO, and the CEO has told me to speak to the sub-county MOH, which we did, and we updated the same.
Unfortunately, Honorable Galunda, you've taken us to the what?
No, sorry, I was giving an example.
No,
so this list, I was saying this list.
Yesterday, you caused that statement, by your own contribution, you caused this statement to be in this order paper. Is what you said about the irregularities. Can we stick to that? It will cover every ward. You are the leader of minority.
Yes, thank you. I remember very well because the minister was giving the names. But in Kikumbulu South, because we had been allowed to send the names of the chairs, in Kikumbulu South, I said people must elect their own people. So they elected people in all those dispensaries. Then one of the two nurses in charge, one in Kalungu and another one in Makueni, and said that she would not pick the people, the person who was elected by the people. So she sent her own people to be chairs for these nurses when it comes to appointments, and they are able to even dictate who comes in so that they can control the board. Now those nurses are in contempt. And I think they should not even be serving our people from Kalungu and also Makueni. And if the department doesn't take charge of these things, we will even flush them out, because we have been doing demonstrations, and I can now do the demonstration in my ward myself.
Your point is met.
Thank you, Honorable Speaker.
Honorable Waziri, I think the concern is now that happened, and you confirm that indeed it happened. The concern of the member is the action that you're going to take, aware that you indicated that the government will bear the cost of regazetting, but then what happens to the commission of that illegality or anomaly?
Thank you, Mr. Speaker. When I got the question, actually, I tasked my team to not just look at the specific facilities, actually go through the whole list. Just for me to get it conclusively done. And that is why the names are as they appear in the response. The chairman's appointment is to be done by the ECM. And then there is the officer in charge of the facility, who is the secretary automatically, and then 2 persons elected. These are the ones who are to be elected by the local community members in the meetings that were held in the facilities. And we got those names. So where the elected members were not captured appropriately, this is something which I'm still following up with my officers. Some who are with me in the department, others who have since moved out of the department, and we will get to the bottom of to know exactly at what point the error, if it was a commission, could have happened. But I would request if I could proceed and making the corrections as suggested, and then as I continue to do the administrative corrections within the department.
I think, are you answered? The corrections will be done.
Yes, the ECM has told you will consider
the corrections.
Yes, the correction, including those on Namali Mulana. Thank you.
Speaker, before I don't need to be unanswered. You know, I have a need, like in my ward and other wards, and Honorable Speaker yesterday was saying other members may even not be aware of what transpired in their wards. Myself, I'm in charge of my ward. One,
Honorable Kalunda, if you are speaking.
Sorry for. So that is.
Order, take your seat. Take your seat, leader of the majority. It is glaring and I've had, and that is why I have switched off. Honorable Kalunda, you are out of order. I don't need to be moved to, and therefore you have to withdraw and apologize to the members.
One, I withdraw and apologize unconditionally. So
no. The matter is tested. I have formally booked an appointment for you with Waziri after this because you are dealing with your ward, so he will sort your matter as an individual. So propose to see him separately. I think the issue on this matter, Waziri, was officers participating in an illegality or facilitating and procedure of your team is what these members are not telling you. In fact, that is the question behind the question. It is not gazetting.
We'll get to the bottom of it.
I can tell you that the member of Emali was interested in that yesterday. Now that is keen, I think he would want to bring a statement after 14 days. But let us address these issues. Now, very lastly, is 5 minutes to go, which I think engineers can be able to sort this matter. This refers to the statement on construction of an isolation ward at Boni Sub-County Hospital.
Mr. Speaker, if I may, I'm still keeping Waziri ICT here.
Yes, please. Yes, please. I will.
You, okay.
I will, because on a number of issues, every other time you talk to automation, and a member also mentioned to me that what is about to see is also bigger, and our presence there has attracted something else that may be a cure to bigger problems that we have. So it's not by default that she's there. She's part of Oversight.
Okay, fair.
I'm very much aware that when you go back to the office, you know the problems ailing system the government. And surely I will give an opportunity. Let us allow Waziri to close the matter on the isolation center. This was an emergency. Dr. Ndolo, you know as I do. Dr. Honorable Kalunda, know as I do, leader of minority, majority, Honorable Moki, Honorable Mbalu, this matter ought to have been concluded during COVID time. Whatever the technicalities, the approach must be with a view to conclude this as if it was an emergency project. So Honorable Mulemba, member from Boni, simply wanted to know, will this be done? Forget about the overpayments and all the big issues are technical, but ultimately we want to know when this is going to come to a realization. You still need the chief officer for works infrastructure?
Yes, we need him here.
Can do so.
If you allow, we can release the MCRH team.
Yes. Thank you, officers under Dr. Musila. You are released. Please don't covet to become executive committee members in future. It's not a nice job. But however, I can guarantee you the heat generated from this house will reach your desks at double speed.
Dr. Dolo, please call your colleague. I think this morning we got the preliminary report, late last evening. I hope members are appraised up to where we are. When we visited Mboni sub-county on 30th November last year and realized the project is stalled, and then we put in measures to do an audit, and quickly, the contractor has since indicated that he wants out, so we had to value what works he had done at that point in time. Monies had paid to the tune of 36 million. The initial assessment that we got, and I think it's filed already, indicated that the works could be to the tune of 51 million shillings. And because of that high, variation between what the initial contract was, the phase one of the facility was supposed to cost.
Minister should answer in summary form whether they did the corrective value and now they disclose to this honorable house what is the value of that building, what has been paid, and all the pending balances in all the financial years and budgets. In that way, Mr. Speaker, we are going now to have the way forward. Thank you, Honorable Speaker.
Waziri, do you have that information, or you need to put up that information together?
We have the information of how much has been paid to the contractor, and Dr. Dolo will quickly take us through that. And then as we wait for Chief Officer Infrastructure is coming in, he will speak into the current report, the one now we've just got from the national office.
So member from board, let me ask, have you seen the documents? So that we don't rush you through the process?
Mr. Speaker, I did not see the documents, but I got a brief.
Now, do you want us to proceed, or we allow you to peruse the documents and then you deal with the matter at committee?
Mr. Speaker, we can proceed.
Okay.
But there's one person who is missing. I don't know where that person is. The officer for infrastructure, who is supposed maybe to give the audit report. After we get that audit report, that matter should be concluded here.
Audit report the member is referring to.
Mr. Speaker, the audit report was shared early this morning, but as our CC has said, this was the advance copy before it was signed, and the team in infrastructure are the ones who are able to share the final report and get into the details. All I can say is what I saw in the report is that the works as built, that figure which was coming to 51 million in that report, which is we are waiting the signed copy, is saying that 8 million. So that is what I was able to grasp in the conclusion.
Fair enough.
But yes.
So what do you do? I've listened to you, honorable member. You've not yet received a copy of that report. It is premature to canvass that matter before us now. So I would direct them with the chairperson committee on health services, and if the technical officer, either by the county assembly or through the office of the CEO, is required in that committee to make clarification, to do so that then within the next 7 days we have a substantive response on that particular matter, making a closure. That notwithstanding, you will be required to give a timeline within which that project will be completed. After that has been resolved, then how much time do you require to get it completed and operational, including then projecting. If there is equipping, you require so much budget, and it will require so much to be done, so that matter is rested. And I thank you, Honorable Moki, for informing me in spirit. Yes. As we make our closing remarks, Honorable Chalomumo has raised an issue on. There's been, he talks about allegations on 750 mortality rate per day in Makueni County. You didn't mention about that, it's important. And he also asked whether you can confirm indeed you don't have unqualified health care workers in this county. Is a yes or no? So if it is not true, no.
Dr. Dolo.
And then lastly, Makindu Hospital was on TV yesterday. Elaborate less than a minute. Go ahead.
Thank you. On the issue of the mortalities that the honorable member highlighted, these were absolute numbers which were picked from the national reporting platform, but we have the standard way of measuring whether these numbers are real or we should be scared or we are within the natural existence where people are born and people have to die. Our death rate is 5 per 100,000 population, per 10,000 population, as opposed to the national, which is 8. So we are doing better than the national. And therefore, when we isolate the figures and start talking about 70, 100, 200 in a certain period, then that is sensationalization of the figures without standardizing them to the world standards. On the issue of qualification of healthcare workers, there is a weakness in the deployment process. Like we advertised, the advert was closed. Right now, as we are seated here, we don't know when the shortlisting is happening. We don't participate in it. It is done by the board. We take our officers to go and interview. We are requested to give technical officers. We don't participate in the selection of the officers who are successful. That is done by the board alone without our technical support. When they come to the department, it's now when we have to chase shadows and try to now find out whether they were qualified. Mr. Speaker, we have had a few instances where we have found an officer wrongly placed, and we have written back to the board and they have been placed in the right place. Like somebody is called a lab technician, but is a nurse. We have had a few instances where an officer is deployed in a certain cadre, but we are unable to authenticate the papers at our side. And through the county executive committee, and we have the 2 members here, we got a communication from the CS for all people, all employees of the county to submit their certificates for authentication. So we probably from this exercise is when we'll know whether we have medics who are not real medics, and even other cadres from chief officers, from directors who may be having fake papers. Probably it will come out at that point. So I would say as a department, we have chased shadows to try and address that. On the issue of Makindu, it's unfortunate because on the clip, we have people inside this department who are actually not working for that one that we are talking about, and they are sabotaging from within. But the CEC has committed that we will go into deeper depths to expose them. So for that one in Makindu, if I would task anyone to cross-check, there is no leakage of sewage as we are seated here. It was just one instance which occurred for less than an hour, and that was 3 months ago. There is nothing right now. So objectivity also in reporting is important. Thank you.
Fair enough. I'll give you the last minute to make a remark, if any. You had indicated that you've come along with your colleague. Your colleague was to speak or to input into your contribution, but along the way, we didn't find a contribution in answering the question. And when you try to explain why she's here, she can only be here to help you or to help us understand the problem and perhaps be part of the recommendations. So what brings you here, the executive committee member for education? I mean, it's interesting when others have to sit there for more than 3 hours answering questions, and you're volunteering yourself before your schedule. Go ahead.
Thank you very much, Mr. Speaker, sir, and honorable members. I want to take this opportunity first to thank my colleague for tagging me along with him, because I have been listening to the conversation very keenly, and I take note that some of the issues that have been raised, actually majorly most of the issues, it's only automation that can be able to address them. I will appraise the House from 3 different perspectives. I want to give you the situation of our health sector automation as is. I will also inform you on what we have been able to do for the last 1 year and what our plans are. Mr. Speaker, the current situation of automation is that we have no visibility of any kind in our health sector. When we came in, Mr. Speaker, so every system does. The last 1 year, Mr. Speaker, sir, it is my pride to report to the House that we have been able to connect about 63 health facilities to the revenue management system. We have the one level 5, Makueni County Referral Hospital. We have the 14 level 4s, and we have the 47 level 3s connected to the RMS, and they are able to report their revenue on a daily basis. So we have that visibility. And it is my joy to also report that with that integration, for the last just concluded financial year, Mr. Speaker, sir, we have been able to increase our revenue for the health sector by over 100 million. And this happened in about 3 months. So just imagine what we can do if we have all the facilities connected. The other thing, Mr. Speaker, is that one of the things that came out, and I believe it was asked by one honorable member, is the fact that the NHIF card, there's a problem when it comes to billing. We have been able to interrogate from an infrastructure point, and we believe that one of the issues that is causing that is because the infrastructure setup, the ICT infrastructure set up at the Makueni County Referral Hospital is not very stable. We are currently on NOFB, and NOFB is a government fiber connectivity, and the reliability of NOFB is not stable. So we are operating at 0 to 100 Mbps, but at some point you may find that we are operating at 0 and some other time, so it keeps fluctuating. So we are currently working to ensure that we have a link, a direct link connected to the hospital from one of the ISPs, the internet service providers, to ensure that the county referral hospital is on a full-time connectivity and we don't have those issues of fluctuation. We can have the NOFB connectivity as one of the redundant links to ensure that when the other link is down, then the other one comes up. Mr. Speaker, for the things that we've been able to do since this year started, is that we've been able to deploy a health products and technologies management system. This system has been deployed in 13 of our facilities, with the exception of the Makueni County Referral Hospital. It is a lightweight system. We did this so that we can at least take care of the pilferage that is happening. We have deployed the same in 7 level 4 hospitals. We have deployed to enforce accountability of all inventory. I'm sure some of the members here have been able to walk into the hospitals and seen that system at work. We are able to ensure that we have interfacility sharing or borrowing. With that visibility, and because it is real time, if we are seated here, we are able to see that Makindu Health Facility has more Panados than they need, and then the other facility doesn't have. So the health sector can actually confirm that for the 13 facilities that we have that system running, we are able to actually see and inter-share within our facilities. So that is something that will go a long way if we have this system deployed in all the 240 facilities. The other thing, Mr. Speaker, is that we have real-time reports. We are able to see the number of
commodities.
Yes.
You seem to have become a doctor. You know, the IT people will tell you the credentials.
Yes.
Kumba credentials is password. Now you are moving from credentials to commodities and non-pharmaceuticals. So don't make it simple for us and for citizens.
Thank you, Mr. Speaker. I was just trying to bring out the point that the importance of automation actually can do a lot of good to this county, and that is one of the things that we've been able to do. I will not emphasize the fact that we've been able to contain 1 year. So what is the way forward from where we sit? The way forward is that this current financial year, the department has an allocation of 30 million, and we've decided to push that money towards the automation of health. And we have connected and collaborated with the ICT Authority in Nairobi to ensure that we undertake a proper feasibility study and come up with specifications, both infrastructure and systems, to ensure that we start the process of integrating the system. So, Mr. Speaker, this is an assurance. We have listened, and basically through the conversations that have happened here today, we have been able to pick some of the key aspects that the House Assembly and the people's representatives want to see. And I believe by the time we are done with automating health, every question that has been asked here today will be answered. I submit. Thank you.
So to address the subject matter today, which was very odd, the Wazir has said we'll retreat in 30 days. Is it possible to have a referral, an automated referral system, so that by the time you're getting to a referral for services, then it's not just a piece of paper. Sure. Then the respective doctor in the referral or sub-county hospitals, when they flag it in the system, then the minister, the CEO, and other levels can be able to know and check the history, what was the basis of that referral, including the contacts of the patient. I mean, the main challenge that we've been grappling with, from when a machine breaks down, there's need for referral. And if then the cost of a scan is 2,000, and then we are transferring the 2,000 to private service, how do you monitor that through that? That's a challenge. So that then we have listened to what you've said, but we also want you to take up the challenges that we have witnessed this afternoon and help.
Thank you, Mr. Speaker. I would answer that by just stating some of the key objectives of the system we intend to automate for the health department. We are looking at 3 key objectives, and the first one is the patient's care, the patient's journey. We take note that that system of referral needs to be automated, so that if you are referred from Makindu, objective, Mr. Speaker, is the commodities management. The commodities management will ensure that the commodities are tracked from the source, the chemicals of this world, the meds, and will ensure that we have a linkage, so that once these commodities are released from the supplier, then they are received or HPTs. So once these commodities are released from the source, then they are received in the system from the point of receipt, be it the MCRH, be it any other sub-county hospital. And the third objective, Mr. Speaker, sir, is revenue collection. One of the things that we want to emphasize and really take care and control is the revenue collection aspect. One of the members stated that some people could pay cash so that some of their services are hastened. Once we have a system, then we will ensure that we have control, so that when you come in at registration, once you pay your registration fee, only then does the system open up for you to be able to be seen by the other specialists. This will mean that one of the issues that was raised here, the time that a patient takes to be served, Waziri here can be able to see this specific patient walked into the hospital at 8 and they exited at 10 or at 12 or at 3. Some of the processes we've seen in the private hospitals, I know some of you have gone to the Aga Khans of this world. That is the kind of system we are bringing on board. We have already started the process, and we have already engaged ICTA to do feasibility study, and our intention, Mr. Speaker, sir, is to have the Makueni County Referral Hospital automated by the end of this financial year. Thank you.
We are way beyond that, and things will be different. I must commit that to the residents of Makueni County. Convert these out to right now. So this sitting stands adjourned. Waziri, you have 30 days to present a response, clarifications on the issue raised to this assembly, after which it will be interrogated and a report will be developed with recommendation to the county executive committee and yourself for implementation. Thank you so much. Thank you so much.